So, scared me. Okay. So today we're gonna be doing our case study. We're gonna start off with our case study on ACT. We're gonna go ahead and let our wonderful panelists introduce themselves. So we can start with the ones who are present, and then we'll go to Dr. Castillo, who's joining us online. So Dr. if you want to start?
Sure. I'm Dr. Chris Lees. I'm an assistant professor here at the university, and I'm the associate editor for the journal.
Good morning, everyone. I'm Christine McVeigh. I'm a registered nurse with a master's in nursing leadership and management. I have had ER experience. I have worked with various veterans over the course of time, so I'm very glad to be here. Thank you.
My name is Jalen Bowman. I'm OPC, currently in private practice, previous work environments with HIV, adult needs, and just want to be here.
Thank you. Dr. Castillo, would you mind go ahead and introducing yourself?
Sure. My name is Gerardo Castillo. I'm a psychiatric mental health nurse practitioner. I am from the Rio Grande Valley. I have a clinic located in McAllen, and I primarily see patients across lifespans, provide diagnosing and medication management for those patients. Thank you for having me.
Thank you so much. Okay, am I missing anything before we start? No, okay. Okay, so I'm gonna pass the mic for whoever wants to answer the question, just so that Dr. Castillo can hear us online. And Dr. Castillo, at any point, if you can't hear us, just let us know and we'll figure it out. Okay, so we have here, let me see. I wonder if you can see. Dr. Castillo, do you have a copy of the case study?
I do. I have one printed
Okay.
out, and I see one online as well.
Perfect, thank you. All right, so I'm gonna go ahead and read this. Let me zoom in so that we can see it better. Okay, so Jill was a 24-year-old Caucasian female referred by a friend to an outpatient psychological services center. Jill was the younger of 2 children in her family, and her parents had divorced when she was in preschool. Jill enrolled in the military upon completing high school and ended her career upon completing 4 years. Jill eventually transitioned to a food services job and had a long history of poor job performance and retention in other low-paying positions. Initially, Jill lived in a small apartment with her boyfriend, who was several years older than her. Due to ongoing issues in their relationship, Jill ended the relationship and began living temporarily in a shelter until she was unable to remain there due to breaking shelter rules for fighting with other residents after they tried to steal her belongings. This resulted in Jill experiencing an ongoing period of homelessness for nearly 2 years. As a homeless individual, Jill faced a myriad of challenges which exacerbated her existing mental health issues and increased her susceptibility to traumatic experiences. Jill's living situation heightened feelings of insecurity, hopelessness, and isolation. For Jill, access to basic necessities such as food, shelter, and hygiene facilities became a daily struggle. The uncertainty of where she would sleep each night and the constant search for resources contributed to her sense of vulnerability and distress. Moreover, living without a stable home exposed Jill to harsh weather conditions and limited access to healthcare services, posing significant risk to her physical health. On occasion, she would reside in other shelters, providing temporary relief from sleeping on the streets. However, Jill was subjected to overcrowding and unsafe living conditions. Jill often had her personal items stolen and got into more fights with other residents at the shelter. The lack of privacy and personal space increased feelings of discomfort and further contribute to her emotional difficulties. Jill's experience of homelessness intersected with her history of substance abuse. The stress and uncertainty associated with her living situation intensified her reliance on drugs and alcohol as a coping mechanism. Her history of using methamphetamine and alcohol as a pattern of self-medication was to her a response to the challenges she faced while homeless. Jill's experience of homelessness intertwined with her mental health struggles and substance abuse issues, creating a complex web of challenges that she needed to address in therapy. Jill was able to secure temporary housing with the help of a local community mental health agency. When she presented for treatment, Jill stated that she needed help with 3 issues: find stable housing or shelter, stop her drug use, and get help in dealing with her sexual abuse history. At the time of intake, Jill reported that she was using methamphetamine 6 to 8 times per month, following her time in the military, drinking alcohol 2 to 4 times per month, and occasionally using cocaine and marijuana. She also reported smoking 10 to 20 cigarettes per day. With respect to her history of traumatic events, Jill met full criteria for PTSD related to history of sexual abuse. By her report, the most distressing aspects of post-traumatic symptoms were intrusive memories of the events and the problems that this caused her in her sexual relations with her ex-boyfriend and people she encountered while homeless. With respect to family, Jill's mother had a history of substance dependence and major depressive disorder, and Jill's father was absent for much of her childhood. Because of these factors, Jill was frequently left alone and not carefully supervised throughout most of her childhood. It was during these periods of inadequate parental supervision that Jill was first sexually victimized. Jill reported that she was sexually abused by her uncle from the age of 5 to 7, and at age 7, Jill disclosed to her mother that her uncle was hurting her, and her mother took her to see a psychiatrist. However, Jill reported that the psychiatrist was a physically imposing older man with whom she didn't feel comfortable. So she didn't speak to him about the abuse and stopped attending therapy after only a few sessions. Jill reported that her next sexual victimization occurred in the military as a result of these traumatic experiences. Jill reported that she felt very different from everyone else and had problems with mood, body image, and self-esteem. In an attempt to get rid of the negative feelings that she was having, she began drinking alcohol with her older brother at the age of 17. Drinking alcohol quickly advanced to using illicit substances following her time in the military, and by the time she was 22, she tried most available drugs, like we talked about earlier: marijuana, cocaine, heroin, Valium, and methamphetamine. Finally, because of her drug and alcohol use, she spent time with many people who are older than her and also using substances. Because of her current and historical problems with substance abuse, Jill qualified for free psychological treatment under auspices of a treatment development grant evaluating the effectiveness of ACT for substance abusers. As part of the grant protocol, Jill completed a number of self-report measures. So this included MMPI, Acceptance and Action Questionnaire, White Bear Suppression Inventory, Automatic Thoughts Questionnaire, Symptom Checklist 90R, and BDI. At intake throughout the course of treatment and at 3-month, 6-month, and 12-month follow-up points. On the basis of conceptualization for this case, it was determined that Jill could benefit from ACT with its focus on reduction of experiential avoidance, acceptance of private events, and commitment to behavior change. Thank y'all for bearing with me as I spoke through that whole thing. So for our panel, we're going to start with question number 1. Are there any additional diagnoses you would assess for? Hey, run this way.
I think the 2 diagnoses that I might assess for, of course, would be major depressive disorder. With all that Jill's been going through, she may meet criteria for that. Also, just to check for the presence of any manic episodes, especially with one of the criteria just being engaging in behaviors that may cause painful consequences, which might be like the drug use or other things. And then also, if she meets criteria for specific substance use disorders, I think she may be using the most, or the substances that she's using the most would be, sounds like methamphetamines and nicotine, alcohol, just to see if she meets criteria for any of those things, just because, diagnosing, one of the purposes is to, help conceptualize the case, but also just inform treatment as well. So just be important to check for those things. And that's kind of what sticks out to me.
I agree with the substance use disorders and major depressive disorder, but I also would assess for borderline personality disorder, right? So she's got evidence of both types of trauma, right? The type 1, that would be the military sexual trauma, the childhood abuse, but she's also got the type 2, the systemic one, the homelessness, mother had some problems, father was gone, abusive relationships. So she's kind of getting it at all angles, right? She's getting physically traumatized, but then also she has no reliable source of support. And so even living in the shelter, right, where she's having to defend herself both physically, but then also her belongings. So she's never able to turn off, right? And so usually if you look up borderline, you'll see these really big flamboyant demonstrations of it. There's also the opposite end where they're kind of hurting on the inside and self-harming, and that may be manifested through her substance use.
Dr. Lee? Dr. Castillo, I see you unmuted.
Yeah, so I agree with them. I would also just like to expand on the manic, right? I would evaluate for bipolar disorder, generalized anxiety disorder, and I would also evaluate for schizophrenia. A lot of patients that are homeless, high number of them suffer from schizophrenia. So I'd probably evaluate for that as well. And I agree with the other one, substance use disorder, borderline personality disorder, uh, major depressive disorder as well. Thank you.
Thank you. So we'll move on to question 2. What are some other assessments that you believe might be helpful when you're working in your respective professions? Okay.
For me, just looking at this, definitely, I would think at every time you see this individual, you would want to be assessing them for suicide. I think there's probably a high risk with this lady. Also, given that she suffered military sexual trauma, there are military sexual trauma within the VA veterans system that she could actually enroll in that are very specialized to that. And the other thing, it talked about her homelessness and being able to obtain food. So looking at those social determinants of health, doing an evaluation and assessment of that to try to find out what those are and where we can go to get resources for her.
Regarding the substance use, I think it's described, and not to minimize or condone substance use. Not all substance use is dependent or addictive substance use. Right now, she does use a lot. Is that a function of dependence, addiction, or simply coping? Right. So I think a substance use assessment, whether it's an informal one like CAGE, right? Have you ever tried to cut back? Have you gotten annoyed because people keep getting on you about it? Have you felt guilt? Have you ever needed an eye opener? Or one of the more formal ones like a SASE, right? To see what is the extent of that on top of just like observational assessments, right? Is she coming in with withdrawals? Is she coming in with intense cravings? Is she inebriated or high? But I think trying to do that would really help, because it would help prioritize where on the list of things that we need to work on does addiction fall. Because if she has a dependence on something like meth, right, we really need to kind of focus on squashing that or reducing it down from a like less lethal level before we can start moving on to other things.
I think some additional assessments I might use would be, the PHQ-9, but also a specific ACT questionnaire would be the valuing questionnaire, which is like a 10-item self-report assessment that kind of just shows how consistently someone's living according to their values. Uh, I think she took the acceptance and action questionnaire. That's something that I've used just to kind of gauge just how, according to that measure, how psychologically inflexible she is, or the behaviors that she's engaging in, which can be given ever so often just to track progress. So I've used that one and of course the BDI, but just another ACT specific one, the valuing questionnaire could be helpful.
Dr. Castillo?
Sure. So I agree. I would also use a GAD-7 for anxiety. Would also do a mood disorder questionnaire. So these and the PHQ-9. So these are quick questionnaires that you can do, and they can hone you in on depression, anxiety, and bipolar disorder. There's also a, Columbia suicide severity rating scale that we can use to see, where she's at with suicidal ideation. Thank you.
Thank you. Okay, so moving on. What are some resources that might be helpful for Jill, like out in the community, things like that?
I think if her substance use is appropriate for it, a 12-step, other shelters, food pantries, things like that. Other support groups, including those for survivors of military sexual trauma, but also when she's ready, since sobriety is something she's working towards and she needs housing, sober living communities, right? And full transparency, it's not like you snap your fingers and you're able to go, but those are communities with other people working on recovery that have systems in place to help reduce chances of relapse and have requirements that you are tested, that you are staying sober, and they have weekly meetings, lots of rules and structure to help those newly entering into recovery who also need to be in an environment or a community with people kind of going through the same thing. And that kind of has the built-in benefit of having a sponsor and a support group of people who are at the same place or further along in their recovery journey.
Some additional resources in the community. Of course, I think MHID could be helpful for this client. Particularly, they have a program there called the PATH program, which is more focused on those who are homeless or facing homelessness. So some services that they may receive there would be case management, CBT if qualified, psychosocial rehabilitation, linkages to other helpful resources in the community that are more focused on helping those who are homeless, getting them linked to, clothes closets, food pantries. A lot of those in the homelessness or dealing with homelessness, they may not have like their documents like IDs, socials, things like that. So they can help them recover those or get new copies. Something else that could be helpful is the Corpus Christi Vet Center. I think she said that she was in the military. So I believe they offer like counseling services and maybe other helpful things that I'm not aware of, but regardless of discharge status. So that could be an additional help for her. I'm sure that they can get her linked up to any other kinds of military or veteran services in the community as well.
Perfect segue. So noting she's a veteran, there's so many resources out there. And I think a lot of them, whether you're in the community or you are a veteran, pretty much mirror up to each other. Some of the things I thought about is making sure she has those resources, numbers to the Veterans Crisis Line. Food pantries has already been mentioned. There is also a housing and urban development veteran assisted housing. They will put these veterans in homes, in apartments. This is a woman also that has a history of military sexual trauma. So sometimes it's really nice to make sure if it's a female that you match them up with female providers for women's health. That's a big thing for them. So being considerate and mindful of that. Um, there's also compensated work therapy. She's had sometimes trouble holding jobs. And so there's programs out there that while you are going through various therapies, you also are in a work program that would be helpful for her. Substance use disorder clinics are available. There's also domiciliaries. Again, it's more of a inpatient treatment facility, but during the day, they're allowed to go off site to go out and work. And then come back and do their therapy. And maybe, further down the line, I don't think it'd be the top priority, but maybe some type of smoking cessation program for her.
Sorry, I got all tangled up.
Thank you. Dr. Castillo.
Sure. So besides those services, I think she would probably benefit from some type of services provided by like MHMR. They tend to provide comprehensive services for patients, including psychiatric services, medication management, and some social services where they kind of go and follow up with patients and make sure they're taking their meds, make sure they're doing good. So I think that would be also beneficial for her at this point in time.
Yes, thank you. So moving on, this one's a very specific question regarding ACT. So how would using ACT be beneficial to Jill? And also if you have any specific interventions that you had in mind for our counselors.
So the primary goal with ACT is to live a valued life or live your life according to your values while accepting, that's the acceptance part, while managing the discomfort that comes with it. And so for Jill, the overall overarching goal would be to, when she has experiences, internal experiences, whether they be about the trauma, later on in her recovery, when she has cravings, when she is frustrated or she ruminates on past experiences, how to kind of acknowledge those thoughts, hold them. It's not CBT where we're trying to change them, right? What we're trying to change is her relationship and her reaction to those very valid thoughts, right? We don't want to say, well, it was a long time ago. Look how you're doing now, right? That really minimizes the experience that she went through. And she is working through those feelings. And it's normal to kind of hold on to that. How many of you still cringe at something you said like 10 years ago? Good. So I'm not the only one. Right. And so this is really serious stuff that she went through. And so there's lots of reminders for her of what happened. And so that would be the overarching goal, right? At the end of our last session, she would be at a place where she can say, I'm having this thought, I'm having this internal experience, I'm having these feelings, and I'm still present, and I'm accepting, I'm willing to continue doing the things I want to do while experiencing this discomfort. The process, without taking away from my peers' times, would be a lot of psychoeducation about acceptance, automatic thoughts, diffusion, the ACT processes. The values assessment would be absolutely critical, right, to figure out what she wants to work towards. And then I think the other one would be focusing on the concept of diffusion, right? Having her recognize that when she has a thought or she has an experience, it doesn't automatically make it true, right? That's her brain signaling, hey, we don't want this to happen again. Don't forget this happened. Don't let it happen again. Having her be able to say, okay, I'm having that thought, and being able to choose what she wants to do with it versus having the thought and immediately saying that I'm never going to get out of this. Like, I'm always going to feel this way. This is the thing that defines me, right? And so having her be able to manage those thoughts the way she would like.
Well, I definitely agree with everything that was mentioned. I think the goal is to help her live a more value-aligned life, reach those kinds of goals, and helping her with that would be helping her teaching her the skills that are in accordance with the ACT core concepts to promote psychological flexibility. So maybe I'll talk more about kind of specific interventions that could be helpful in that regard. Um, so, acceptance and cognitive diffusion skills, such as like leaves on a stream, you know, um, an exercise that can help someone kind of get out of their mind a little bit, just allow thoughts and feelings to come and go without kind of trying to control them, avoid them, hold on to them. Um, an exercise I like to do with my clients is called the noticing exercise, which is kind of similar. Um, just having them for a moment kind of drop in more into the present moment by noticing things like bodily sensations, thoughts, feelings, sounds, and the noticing itself, which aligns more with kind of the self as context core concept. But also, I like the use of analogies and metaphors in ACT, like passengers on the bus. You know, the the bus is kind of like the journey in life, right? And then in life, you pick up things along the way, thoughts, feelings, memories, and it can help a client become aware are your past experiences, are uncomfortable thoughts and feelings kind of driving the bus? Are you listening more to them to make the decisions for you, or are you taking more control despite kind of the presence of those things? Um, and also another one would be the wheel of suffering, um, which can help a client outline just the become more aware of the things that cause them pain, the reactions to those things, the behaviors they may engage in to avoid them, and the consequences of engaging in avoidant behaviors. Um, and then last one would be just the ACT matrix, which makes the client more aware of internal and external experiences, the behaviors they engage in to that more move them away from their value aligned goals, and then kind of what would it look like to move more towards those value aligned goals in the presence of those things. So I think those would be helpful, some of the helpful interventions that can um, help her move more towards a life that she would like to live.
I can go ahead and move on to the next one. Um, so how would you include other professionals to provide treatment and an integrative approach? So this is very important because all of our students do work at sites where they work alongside medical professionals. So we get to have an in-depth view today since we have 2 medical professionals with us. So how would you include other professionals?
For me, I was just thinking about the approach of always having these interdisciplinary team meetings where everybody comes together and you specifically review that patient's care and treatment. And so I would definitely consider including, as already been said, social workers, mental health providers, women's health resources for this, and of course your military sexual trauma. But it's always sometimes, and you'll find this, sometimes it'll be maybe somebody that has more of a food disparity. So at that time, you may need to involve a dietitian, but just always keeping a broad mindset of who all could have a point in care for this person and bringing them into those discussions so that everybody can put their thoughts on the table. You find when it's a collective group, I feel like a lot more can be accomplished and the patient benefits from that. So instead of keeping things very siloed, having those open discussions and bringing more people to the table.
I agree. And having a psychiatric prescriber who can help manage symptoms. I also think having an addiction specialist, especially maybe someone with more on the medical side, if she needs that supervised detox, right? Depending on how severe it is, it might be that she needs to be supervised or she needs to be, I'm blanking on the word, but essentially she needs to be weaned off of the drug use, right? And she may need medication to deal with any withdrawal symptoms. That was one of the first things I thought. There will be, I would imagine, especially since she has been diagnosed, she met the criteria for PTSD. She most likely does have a mood disorder. Medication plus counseling would give the best results, right? So I think working with prescribers and counseling and addiction specialists, that'd be great. And then working with social workers and community resources, which would also further reduce anxiety and hopefully mood issues as she's getting the support that she needs and is realizing, okay, I'm safer. I'm not in that same situation anymore. There are resources, there are people I can go to, there are places I can go to for help. And so I would expect the combination of all of this would reduce any kind of symptoms, or at least the severity of them, and then increase optimism, hopefulness, and self-efficacy.
So again, I agree with what was said, so I'll be a little more brief. My answer might be more reflective of my experience at MHID. So I think I would definitely want to be in contact with the case manager of this client. Um, one thing that I thought was helpful at MHID was definitely that contact with the case manager, but we can discuss like what could be what is helpful for this client and how that might look is if this client's doing really well with learning specific skills, act specific skills, then when the case manager is meeting with the client for skills training on their own, maybe we can make the suggestion that he or she could do more mindfulness-based skills with this client just to add on to that. And also in what could be helpful is, consulting with the psychiatric provider. I would be curious to know what are they noticing in terms of the client's progress or regression in their treatment with them, and just kind of bounce ideas off of each other, because it's always good to see or to know what other professionals are seeing. Maybe there's something that I'm missing, or something they mentioned to them that they could share with me that might be helpful, of course within confidentiality and all of that. But and that's something that I really did enjoy when I was working in an integrative setting, is just the regular consultation that went on and just bouncing ideas off of one another.
And I just wanted to add on to your piece there about um, finding out from the other healthcare providers, what are they learning from this individual? Just going back when I was an ER nurse, I would bring a patient in, get their assessment, what are you here for? And write that all down. And the medical doctor would come in and get a totally different story. So it's really great when you can do this interdisciplinary team meetings on these patients, because you get to hear the stories that every one of those treaters is hearing from this individual, and it may be able to help better adjust care or to pinpoint, hone in on a specific area.
Sorry. Thank you. Dr. Castillo.
Sure, and I'll talk from my standpoint as a psychiatric provider and prescriber, right? I very often prescribe medication for patient, but I refer up to 90% of my patients to therapy because I'm a believer. I know therapy works. I usually tell patients, medication can only do so much, and this is where therapy comes in and works with the rest, right? I also very commonly refer patients to physical therapy, dietitians, social workers. I staff and consult with CPS, APS. Counselors sometimes will reach out to me and we'll staff or have a conversation about a mutual patient. I also integrate spirituality, and I tell patients it's very important for you to be spiritual as well, if that's what you believe, right? So sometimes I will refer them to their spiritual leader as a form of comprehensive care. But I think that addressing mental health in all different angles is much better than just medication. So I really love referring patients to therapy. Thank you.
Thank you. Okay, so our next question is, what suggestions do you have for novice professionals to be mindful of when working with a case like Jill's?
I think from the case study, I would be willing to bet she has a high distrust for most people. And so I think you would have to work really hard to work on that rapport and that trust. And for her to fully open up, and just be patient. Don't push, don't rush. Also be able to refocus her, because I think there may be times when she wants to revert back and we want to get back to the present, and keep her focused on whatever topic it is that's being discussed that day, and always just be respectful of their values, their cultures, those types of things.
One suggestion that I'll make is also given what the treatment goals are, but just kind of based on the case study, it seems that um, something that she's struggling with a lot are those symptoms of PTSD. So one suggestion I might make is to be careful not to jump before the client is ready too much into the treatment of that trauma. I think you could be in danger of re-traumatizing the client, if they don't have the necessary skills before they're ready for trauma processing, throw them out their window of tolerance. So something to help mitigate that, as a when I was a counseling student, I really wish that there was like a course for trauma treatment. I think I'm still waiting for K-CREP to kind of mandate that. So something to think about would be to get specific training on trauma treatment. There's a lot of them out there. I just finished an EMDR training. Other ones, CPT, somatic experiencing, sensory motor psychotherapy, and others. But of course, there's actually a training on using ACT for trauma as well. If you go to, I think the website is called praxis.com, and it's probably like the main site that Stephen Hayes uses for his trainings. So they're like really intensive. And there is one training that he has that is using ACT for trauma. So if you're interested in learning more about ACT, like really in depth, there's other ACT trainings that you can get even for cheaper, right? But if you want something more in depth, I would recommend that site. But I would definitely be wary of treating trauma symptoms if you feel like you lack the education and training to do so.
I agree. And with any client, right, we're kind of following their lead. With trauma survivors, it's especially important that we do so, right? They've already been invalidated prior to meeting you. And so if they come and they say, this is what's important to me, this is what I'd like to work on, it's not that you don't get to have an opinion. You, of course, do, and you can even share that in an appropriate way. With somebody like Jill, who has had a lot of trauma, and especially the systemic trauma, if she's telling us, I want to work on being a better mother, I want to work on getting a job, I want to work on these things, and we kind of have a different idea of what's important, that might be based on our own values. We should ultimately respect, with the exceptions of suicide and severe substance use, if that was present, that I do think should take priority. We can't get any of the other goals if she's not functioning or if she's dead, right? And so otherwise, the things that she wants to work on, that is the direction that we should move in. And in my experience, doing that, that works. We go, and if something else they realize later on takes priority, they'll let us know, and we can pivot. It's going to be a marathon, right? There are no quick solutions, right? It's not a quick process. Some of you have heard me say, I wish somebody would have told me that counseling can be slow sometimes, right? And that's not reflective of, in Jill's case, reflective of her. It's reflective of the severity, the frequency of the problem, and then the nature of the problem, that there are recurrent mood issues, there are PTSD symptoms, there will be issues related to substance use. And so it's important to understand that as she goes through it, she will experience discomfort, and she will probably try to avoid that discomfort. A novice counselor, none of which are here, right? You're all experts, would take that to be, oh, she's not serious about it, she's resistant, right? No, she's protecting herself, right? That's the premise of ACT, right? That when discomfort arises, I will try to control it. And usually that results in avoiding. So she might come in, she might not want to talk about something, she might reschedule, she might cancel. And those are not indicative of anything other than this is really hard, right? And so, and we can address that with her. It doesn't mean you ignore it. It means don't rush to say, okay, well, I don't think you're taking this seriously. I guess it's not that important to you, right? That kind of gestalt poking, right? We're not going to do that. But it is calling attention of, I noticed that you're not talking as much. I noticed you're getting frustrated. I noticed that we're canceling and rescheduling a lot. What's going on? Is this uncomfortable for you? Which is what an ACT practitioner would do, right? That's part of being supportive, monitoring and seeing how they're doing in session and calling attention to that and seeing, well, maybe we need to take a step back and say, even talking about getting better can be difficult. So for new counselors working with someone who's experienced a lot of stuff that Jill went through, it is be gracious to yourself, right? Take your time, don't make it a reflection of you, but also appropriately kind of conceptualize what's going on here, and that her behavior serves a function, right? There's a context for it, which is I don't want to talk about these things because it gets me upset, right? Or makes me think things I don't want to. So being patient with yourself, being patient with her, but also really checking in and keeping the goal and the concept of avoidance and control in mind while you're working with her.
Thank you. And Dr. Castillo.
Sure. From my standpoint, I would say be non-judgmental. So typically patients that come and see me are really anxious and, they're going to express how they feel and their thoughts and their emotions and what they've been through, sometimes traumas, right? So I really just tell patients, look, this is a non-judgmental room. I'm not going to judge you or your family in any way. And as soon as I tell them that, I can see that they relax a little bit more and they're more open about it, and I can get a better evaluation and a better sense of where they're actually at. So it's real simple, but just be non-judgmental and provide that experience to those patients so they can open up and give you a little bit more information than what they're giving you. Thank you.
Yes, thank you. Okay, so last but not least, I'm going to rephrase this question a little bit, but in your own profession, what personal example can you share regarding clients with similar symptomology? Just that's the question. And then specifically, if you have an ACT approach, please integrate that as well. So what example can you share regarding clients with similar symptoms? So Jalen. Okay.
I think one personal example that I can share and is the use of a specific intervention and kind of what I noticed happened. I have a client that I was working with who was making good progress and then started saying that she was noticing kind of past memories coming up, uncomfortable past memories, and that when these come up, that she actively tries to distract herself, right? Of course, distraction has its place, but we were at this point where we felt that implicitly, where we felt that distraction could be another method of avoidance. And so a suggestion that I made was, if we can just take a moment to um, drop into this present moment and hold space for this memory, and let's be curious about it and see what comes up. So, she was able to do that, to sit with the image, to um, become aware of the bodily sensations, the feeling, and also kind of be cognitively diffused with it, just to kind of watch it as well. And what ended up happening was that, one, she was able to sit in that moment with those feelings, so didn't need to distract, and two, she actually had some insights in that moment or following that exercise, and so she's able to kind of process that memory. And one thing that she had mentioned was like, without going too much into detail about the memory, but she was saying how she noticed how I take fault for things that aren't my fault, and that could be because I'm trying to protect myself. Maybe if I take fault for something, in that moment, then it might save me pain if I didn't. So it was just interesting to just kind of allow her to, and it suggests that she drop into the present moment, just to be curious, see what comes up from this cognitively diffused place, and it was interesting to see what came out of that. So that's just one of many examples, but that's what could happen with utilizing specific ACT interventions related to the core concepts, and it was kind of cool to see.
So one of my longer term clients years ago was a college student, and she was getting ready to graduate, and we had worked together a long time. And one of the things that we realized was that she used sex as a way of avoidance, right? When she got overwhelmed, she would go find somebody and hook up with them. And that trickled into all of her relationships, right? Because she wound up betraying so many of her partners. On top of that, she was feeling really bad about it. We worked on it a little bit, and one day she had something moderately serious happen. She missed, you guys can relate, she missed the graduation deadline. And so she freaked out. And she came to my office, which is fantastic, right? That's what I wanted her to do, because I wanted to catch her in a moment where she had intense distress. Because one of the things that she was so discomfort adverse that she would never allow herself to experience it, right? She would go run off, find somebody, get high, drink, sex, and all of that. And so we met in my office, and she's panicking. And she said, I just need to go meet somebody. And is this going to fix the situation? And the answer is no. And there is a part of her that knows that. But it's the intensity of this fear, the intensity of, I made another mistake, their long history of blame and shame. And so we did some mindfulness exercises that were similar to the ones suggested earlier. And she was able to kind of cool down and go maybe from a 10 to a 7, right? We're not going from like 10 to 1. That's not going to happen. She cooled down enough to go to a problem-solving place. And she figured out what to do, right? I should email this person, give them a call, and she got the whole thing figured out right there in my office. And then she felt this immense relief, and the avoidance call, the call to run away and distract herself, went away. And so the takeaway was, you see, you were able to handle not only this uncomfortable situation, but one that's intensely uncomfortable. All of us can imagine what that would have been like to know I missed this deadline and now I can't graduate, right? I think all of us we'd all freak out. And so for her, it was kind of this empowering, like, I was able to do that. Does that mean she handled the next situation as well? No, right? That's not what we're going for, but it is to start planting the seed of maybe, just maybe, if I give myself a second, I can figure out that I can hold that discomfort and still move forward. So she was able to hold her shame and her panic and her fear, and also take steps towards remedying this problem, which would also take steps towards one of her values, which was education, right? And so she was able to do that. We worked for several more months, and she continued to improve over that time, and really kind of got to a place of realizing, when I have these intense thoughts and feelings, I shouldn't act on them immediately. I shouldn't dismiss them, right? That's not the point of ACT, but it is to recognize I feel this way. And if you want to go deeper, I feel this way for a reason. What can I do while feeling this way that isn't going to set me back or make me feel worse, right? Because often when we try and control and avoid something, it compounds the problem, right? So if she had done what she wanted to do when she missed that deadline, it just would have missed even further. The day would have closed, and the person who could fix the problem would have left and say, now too much time has passed, right? So there's a little bit of damage control that's done, but she had to give herself the opportunity to realize that she can both experience this incredible anxiety and anger and fear, and still do what she wants to do. And I can only imagine how empowering it must felt for her to realize, wow, I was able to do that. Now we can start growing more and more and more. But that was a really neat session. I had to have seen somebody go from a 10 down to a place where they could problem solve. And I was really proud of her. It was a very powerful moment, I think, for her and me.
Okay, so I am mindful of the time, and I want to respect y'all's time, but if you wouldn't mind staying behind a few minutes in case any of our students have questions. Okay. So if y'all have questions, I'm gonna run. Okay. That way Dr. Castillo can hear us.
Hi, I don't know if you can do it. Is it from this? Sorry, guys. So you brought up the wheel of suffering or the will of suffering. Would you mind speaking more on that? I've never heard of that before.
So more about the wheel of suffering. I know, and it's true.
Yeah, so Wheel of Suffering is an intervention, an act, one that I've seen actually just recently. And so like the idea is um, it could be like a diagram. So like in the middle could be those specific experiences that cause pain, if that would be like bullying, right? On the outside of that, what are the thoughts and feelings that arise as a result of that? I'm I don't know, anything that you can think of. I'm a nerd. I'm, something, and I feel helpless. And so on the outside of that, um, what are the things that you do to avoid those uncomfortable thoughts and feelings? Um, I am on my phone all the time. I don't know, I smoke weed. Just whatever it is to get away from those kinds of thoughts and feelings. And then on the outside of that, what are the consequences of engaging in those behaviors, right? As a result of doing drugs, I'm becoming a person I don't recognize. I'm being taken away from my values, XYZ. So it can really make a client more aware of course, the situation that may be causing those thoughts and feelings, but also what my maybe unhelpful responses to those things. And with that awareness, then we can make more informed decisions that are aligned more with our values. So it's just a helpful intervention in that regard to bring more awareness to our responses and if they're taking us further away from our value aligned goals or moving us to more and we need to move more towards our goals.
Other questions? Okay, Sabrina.
So, as far as a client with maybe severe trauma, do you believe, so being a novice counselor and not maybe having training in trauma, how would you go about kind of reaching their goals? Do you believe it's possible to reach their goals without ever really touching that trauma, or kind of any advice on how you would do that?
Okay.
I think that's a good question. So I might answer on the fly in this moment. I think it just really depends on what their goal overall is, if I can think of a specific example, maybe a goal could be, uh, and I might not go specifically with what she's mentioning. So maybe a goal could be that I want to get a new job, but I noticed that in my past jobs, with the customers that I come in contact with, it brings up reminders of the trauma, the things that they say that people might look the same as some perpetrators, whatever it is, um, but in helping her get get that job, it could be one goal could be to help learn some skills to more emotionally regulate. If you want to take like a CBT route, of course, dealing with unhelpful thoughts and feelings and how we can use those skills. But let's just say that, she was able to effectively use emotion regulation skills, other helpful skills that can, help her feel more capable and confident in getting a job, a reduction in depressive symptoms, a reduction in anxiety symptoms, and um, that she may as we review treatment progress, we might feel like she may be like, what, I've reached my goal. Maybe I don't want to work on trauma specific, or maybe I'm actually ready to work on something like that. And you can have that conversation with her. Of course, if you feel like I'm not capable or competent enough, you can make that referral if you feel like it. But I think it just kind of depends. And then also sometimes what may happen is, especially if you're using like a lot of the core concepts of acts, some things kind of like resolve themselves in a way, so it just kind of really depends. You don't mm, I think I'll just stay there.
Yes. And also, I agree 100%. A client might come in and they have experienced any variety of trauma and they don't want to talk about it. And you know, I really lean into motivational interviewing and kind of roll with that. And you know, for all I know, maybe they truly can have their desired life without ever talking about that trauma. I don't know that they can. So if they come in and they say, I don't want to do that, I say, okay, you know, that's all right. We'll do that. And usually one of two things will happen. One is I'll get, so you're not going to make me talk about it? And I will say, you told me you didn't want to talk about it. And they'll say, but aren't you supposed to make me talk about it? Anyway, it's like, do you want to talk about it? You know, and so we kind of get there, right? And a lot of times from, and this is just anecdotal, this is not something I got out of research, is that they're not used to having a choice, right? They're used to somebody saying, you need to do this. And so when you go and you say, okay, cool, let's focus on getting a new job, right? Let's focus on conflict management with your roommate. It kind of is a new sensation for them. The other thing that happens is that they will try and we'll move forward and we'll focus on how, you know, how to get the job you want or how to, you know, manage your test anxiety or, you know, whatever the issue they want to work on is. And what happens is maybe they accomplish it, but they still don't feel really fulfilled or the problem doesn't get resolved. And slowly, because I'm not going to egg somebody on, right? I do that with you guys, not with them, right? But it's, hey, they start to realize maybe they start drawing the connection that maybe my traumatic experience is kind of getting in the way, right? So I went out with a group of friends, and maybe they're a survivor of interpersonal violence. They go out with some friends. There's a guy there, raises his voice, raises his hand to high five someone, and they kind of panic because it brought them back to their trauma. And then they start piecing together, okay, I think I have that. And so we're going at their pace. And like I said, and I've had clients who I thought, oh my goodness, there's no way that this experience does not interfere with your life. And I've been wrong, right? That biopsychosocial model, they just had the resilience to hold that experience, acknowledge that it happened and not let it affect them. They were just that, I don't know what the word would be, stalwart, that they didn't let it affect their life, and more power to them, right? And so I guess the answer is it can happen. You just won't know until it either does or doesn't with your client.
Okay. She had her hand up and then I'll come back this way.
Okay, I came prepared this time. So I have this scenario that's going to tie into the case study already present. So in an effort to kind of prevent, oh, it depends answer. So imagine that you were already 6 sessions deep into working with the client. So y'all have already like worked on developing those mindfulness skills, the relationship rapport is there, as well as she has some skill in using diffusion techniques. Now she is ready to conquer the meat of it, you know, with regards to her use of drugs as a form of experiential avoidance, which, and mind you, I'm novice, so which is going to involve acceptance, I think. And so I wonder, how would you broach or guide her through that process of acceptance of what had happened? Because from what it sounds like, that experiential avoidance stems from that sexual trauma that she experienced, and multiple factors, of course. So I just want to hear y'all's responses from an ACT perspective.
Yeah, just Jane.
You know, if with Jill, especially, you know, if we are clear that she is using substances as a means of experiential avoidance, you know, and we kind of want to target that specifically, you know, something that could be helpful is just to kind of map out, you know, the process of like what what happens when the urge arises, you know, really map out kind of the pattern of the use. You know, maybe she might be like, when I feel frustrated that something doesn't work out, I start thinking about all the times where I feel like I have failed. It brings up, all types of feelings. I then notice that I have the urge to smoke, and then I go find a corner and I go smoke. Um, and this is a simplified kind of response, right? But if we can map out all of that, um, it gives us the opportunity to use skills like acceptance right where she notices those uncomfortable thoughts and feelings, and making the suggestion that instead of going to our usual pattern, which, if we use interventions like the matrix, would you say that smoking um, moves you more away from your values or more closer? I would assume that she'd say more away. Are you willing to try something different? So make this suggestion that in this moment, even in the session itself, let's plan it out. Let's do a role play. Even, you know, um, imagine that something frustrating happens. Allow this thought and feeling to arise. Now, let's see if we can just kind of hold space for it and see how that goes for you. If it goes well, then can we make that kind of like your homework, and let's kind of track it. How many times can you do it within this week, and it's okay if it doesn't work out the way that we would like it to work out. You can come back and talk about that and what else could be helpful. But I think you, and this again is a simplified kind of response, but I think that could be a way in incorporating things like acceptance in that way with the rising of the thoughts and feelings and the urges that lead to those behaviors that take her away from her value-based goals.
Mighty bold of you to assume that I won't get "it depends" in there. So just to make sure I understand. So Jill is willing to try where she's at that place. Has she stopped the substance, or she's willing to try to stop the substance? Okay. I go big energy, right? Like, all right, let's do this, right? So you're not going to use it all, right? And I try and be like not sarcastic, but over the top about it, because I do want them to have permission to not be perfect, right? And we oftentimes with clients, they have lofty goals, and so do we, and we need to kind of scale it back, because I don't want her to feel like I can't do this. And so very similar to what Jalen said, right, is acknowledging what's going to happen, right? And there's a couple things that, and this is how I'll say it. So Megan, I'm going to talk to you as though you're Jill, okay? I'm going to call you Megan, because you're Megan. So Megan, you're ready to do this. Okay, so if you get uncomfortable, you're not going to use. You're going to try not to use. I like it. Okay. Now, this is what I think is going to happen, right? And it's not because of you. This happens to everybody, is that you're going to have a thought, or you're going to have a feeling, and you're going to try to manage it. That's what we've been working on, but you're going to try and manage it without substances. And what happens is that thought, that feeling, that anxiety, it's free to roam. And it might, and I hope it does, just kind of leave. It just leaves on a river, right? There's also a chance that it might get louder, right? That's your brain screaming at you like, I'm talking to you. I'm talking to you. Remember that thing, right? And so before you use, I want you to try a couple things. The first thing I want you to do is I want you to try and just take a deep breath and ground yourself. The second thing I want you to do, if that doesn't work, is I want you to acknowledge the thought and thank your brain for it. Right? I want you to say, thank you, brain. I hear you. I got it. I had a horrible experience in the military. Thank you, brain. I get it. I'd feel better if I was high, right? Just acknowledge it and put it on a shelf behind you. Imagine a shelf behind you where you can put it there. You can always get high whenever you want. You don't have to do it the second your brain tells you to. And I'm going to pause for a second. We're trying to empower her to make the choice that the thought does not control her. She can have a thought and make a different decision, right? And then if that still doesn't work, if you're really uncomfortable, I want you to try and acknowledge it, be gracious to yourself, and wait it out. So I do put in a little bit of DBT, distress tolerance, right? And so wait it out. If you wind up using, that's okay. I don't want you to blame yourself, right? I don't want you to feel bad about it. You were doing what you needed to do. to manage what sounds like a really uncomfortable situation. I do want you, this is your homework though, from the time that you have the thought or you notice you have the thought to the time that it passes or the time you get high, I want you to track that amount of time, right? And that's going to be our way of measuring how long we got to try and make it, right? And if you notice, hey, after 5 minutes, I felt okay. And we know we got to make it 5 minutes the next time it happens, right? But it's okay to feel uncomfortable, and we're going to keep working on it. But I'm so excited for you, right? And so I'd say go for it. You know, that's what I do with clients. But we also set realistic expectations, right? You're not going to disappoint me, and I don't want you to disappoint yourself. And I'm just really excited and happy that you're going to try this. That's it. So we're kind of explaining what to expect. Does that kind of answer your question? Without it depends. You're welcome.
Okay, that's about all the time we have. So thank you all for participating in our panel discussion. We really value and appreciate your insights. And thank you, Dr. Castillo, for joining us online as well. Okay, so we are going to take, for those of us who have to stay for the training, so all of y'all, we can be back at 10:30. 10, how many? Oh, if y'all are gonna make me do math, come back 15 minutes from now, huh? 10:40, come back at 10:40. Okay, it's your training, we're just living it. Let me pause the recording.
Well, welcome back, everybody. I'm Dr. Lee from one of the projects. I introduced myself, I know. And so I'm going to cover acceptance and commitment therapy. I'm going to go over the main parts, and hopefully with them, we'll be able to see or discuss how it applies to integrated behavioral health, because it is one that is often used in healthcare settings. There's a lot of research for that, and once we kind of go over the premises, you'll see that it probably applies to a lot of other conditions outside of mental health. So what we'll cover is what is ACT, the goals of ACT, psychological flexibility, the processes, its applications to integrated behavioral health, case conceptualization, cultural consideration, and invitation. Assuming we have time to get. So what is acceptance and commitment therapy? When people talk about it, there's a couple things that always happen. One is counselors and clients will often think acceptance, like just be okay with it. Like that's not what we're saying, like just take it and that's the end of it. The other thing is that people will Google it and they will see the hexaflex, right? That diamond looking thing with all the words around it and kind of panic. Or they'll see something called relational frame theory, and that kind of freaks people out too, because it gets technical very fast. And so I don't want you to do that. I'm going to cover those things, and hopefully, if I do a good job today, you will all leave here feeling more confident about this and see how it could apply with your clients and in your integrated settings. So ACT was originally, I'll say, created, conceptualized by Stephen Hayes, and he's at the University of Nevada, Reno, and he came up with it kind of in the 60s. And then he had a very long period of time where he never spoke about it. And what he was doing during that time was he was researching. He was doing a lot of randomized controlled trials. He was doing a lot of studies on it to establish that it works. Russ Harris is he identifies as a psychotherapist. He was a physician before that. And he does a lot of practitioner-oriented things. Right? You will see those two names come up all of the time. It's considered a third wave behavioral therapy, right? We went from behavior therapy to cognitive to this. It's built on relational frame theory. The best way to think about it, like if you had to tell a client in like 2 seconds, is it's like CBT and existential. Not that they would know what either of those is unless they've been counseling before. but it's about your thoughts and meaningfulness in your life. That led to acceptance and commitment therapy and psychological flexibility. This is Stephen Hayes. And one of the things that brought it about, because I think knowing some of the history about the theories really helps understand what it's about, is he really liked behavior therapy at first and saw that, you know, stimulus response type treatments were effective, but they left a lot out. Then looking at CBT, when we start looking at thoughts, behavior, right, there was even more, but felt that thoughts are really automatic and they leave out quite a bit. He was also just really interested in language and the language of our thoughts, right? So I'm not good enough. I'm not man enough. I wish I was prettier. I wish I was more capable. What do these words mean? And he himself, and he still currently does, struggle with tinnitus, the ringing in his ear. And so he does actually practice what he preaches. Right? And so he does a lot of research, and you'll see his studies a lot, and his books are very good. Russ Harris, he really liked ACT also. He has a very strong practitioner presence. In fact, there's a Facebook group called ACT Made Simple, and he moderates that. And it's just astounding the amount of information and resources that are on there. He actively answers questions, right? And so he has lots of YouTube videos that are both intended for clinicians of any variety and for clients to help understand some of the concepts. And for him, he was a physician at first. He didn't want to be a physician. He came from a family of physicians, right? His grandparents, his parents, and then all of his siblings. And he grew up in the UK, went to medical school, didn't like it, moved to Australia. And that was one of the things, right? Even says now, I don't know what I thought was going to happen. I was just miserable then in Australia, right? I don't want to be a physician. Medical school was a drag, it was very difficult. And so he was eating a lot of his feelings, right? And knew he had to change. And so he then learned about how, and he started following Stephen Hayes and learning about him, kind of applying it to himself. And then he found in his medical practice, he was spending more and more consultation time, not only going over mental health stuff, but going over values and action and how you live your life according to those values. And then he fully transitioned from medicine into mental health. So Stephen Hayes came up with the term that is third ways, and he kind of said it just in passing, but it's stuff. The history is that it started with behavior therapy. Just if you know, fake it till you make it, right? If you change your behavior, everything else will change. Then we had CBT. And then there was this little offshoot called functional contextualism. And that's where Hayes is saying that your behavior isn't just random. It's not for any old reason. Your behavior serves a purpose. And there are other theories that also have that premise. But he also brings up that your behavior is based on history, right? So you learn something, this worked in the past, this works in this context, right? So the takeaway with this is that perhaps all behavior, or when we're working with clients, their behavior does something. It's not just a random behavior. What does it do though? And does it move us towards or away from our values and goals? So what he found was that CBT works conditionally, and this is not a criticism of CBT, is that there were some people who really take to it, right? They truly have these cognitive distortions and challenging them and working on the negative core belief. But there were some people who were kind of stuck in their feelings, right? They were stuck with the experience. And that's what's really difficult. And that's what drew me to ACT, is that we can challenge thoughts all the time, but the person can still be left with their feelings, right? You can accept a thought as being distorted or faulty, or you can rationalize it and still be unhappy with it, right? There's this very human, feelings-oriented piece. And so what Hayes thought was, if we can distance ourselves from our thoughts, we can do something with them. We can change that relationship. And so initially it was called cognitive distancing, right? Can you observe the thoughts like a leaves on a river? And what he found was helping, working with people who struggle with depression and obesity and their feelings around obesity and food cravings and diet stuff, that as they were able to kind of put some space between their thoughts and themselves, they were able to improve their lifestyle. And so what that looked like was that somebody who maybe struggled a lot with cravings, initially they will say, I'm craving something. I want, like I have a huge sweet, right? I want candy, I want sugar, sweet sugar. And distancing would be, I'm having the thought, I'm having the craving for sugar, right? I'm having the craving. So what am I going to do with that craving versus what am I going to do with myself? And so as a person kind of distances themselves or separates themselves, their identity, their personness, their personhood from a thought, the person can make different choices, make different decisions, because they can recognize it as, that's just a thought, that's just my stomach or my avoidance or my brain saying, hey, feed me, give me sugar, but I don't have to do that. In fact, maybe it's an automatic thing, right? I get stressed and I want sugar. That's my brain's response to stress, right? It doesn't mean I have to do it, it's an automatic thought. But to improve, I got to be able to identify that it's a thought and not me truly being hungry for something. And that brings us to relational frame theory. I'm going to go through this fairly quickly. It is a very optional, in my opinion, and I think even Hayes says it is an optional aspect of acceptance and commitment therapy. This is very language-based. This is a linguistic thing, and it is a viable theory for counseling. And it has to deal with how we relate concepts to one another. Some of our thoughts, just like with CBT, some of our thoughts are active. And some of our comparisons, that's what I mean by relating, are active. I am bigger than my daughter, right? I'm smaller than Andre the Giant, right? And so those are accurate. Other things, though, are faulty, such as successful people are good at math. I'm not good at math. I'm not successful, right? And the thing is that sounds very kind of simple. These things happen implicitly. It's an autopilot, right? And so I have an example in a second. A relational frame is how two or more things relate to one another. That can be bigger than, smaller than, the same as, below, above, top, whatever. In practice, this is a common one. Maybe it won't relate. We have the idea of math is hard. How many of you are not math people? Yeah, I'm not yet. You're good. Something we're safe. No numbers today.
Okay.
Math has numbers. So math is the same as numbers. The same way we might say a picture of a cat, right? In English, it's cat. In Spanish, it's gato. Right? And so if I said point to the feline, regardless of your spoken language, everybody would point to that. Cat, feline, gato, all mean the same thing. So in our minds, early on, we kind of get the idea that math means numbers, and the reverse is true. Numbers mean math. The class psychometrics has numbers. You see where it's going? Oh, Dr. Hyde. He's right here.
Y'all love psychometrics, right?
So, what does this mean? Yeah, psychometrics has numbers. Psychometrics have numbers, so that means psychometrics has math. Even though it's not, we're not doing math, right? We're explaining standard deviation and statistics, right? We really want to splice it. But I'm not good at math. Remember, psychometrics is now math because we've just attributed anything that has numbers means math. I'm not good at math. I'm not good at numbers. That means I'm going to struggle in psychometrics. But this happens instantly, right? We don't even give them a chance. We don't let them say. We just say, that's there. So reflecting on your life, how many things did you pass up because it was simply, oh, I can't do that, because there's this sequence of sentences that all kind of connect to, I'm not gonna try out for this team because trying out means, I might fail, and failing might make me feel bad, so trying out means I'll feel bad. Going to grad school is hard. I don't like hard things, therefore I won't like grad school. And so people really do pass up opportunities quickly because they have these implicit thoughts. I want to emphasize how optional this aspect is. You do not need to kind of splice down a person. You can if you want, like if that's your thing, and you can do it effectively, you can. But Hayes and Paris are pretty clear that this deals more with how the construction of a thought and the meaning of a thought and how it operates. But if you don't want to kind of go down that rabbit hole, that is okay. Not that CBT or ACT is like the combination of CBT and existential, right? CBT, we're aware of thoughts and feelings. We use that ABC model, and we focus on behaviors. We have the cognitive triangle, right? Your thoughts lead to your feelings, lead to your behavior, and lead back to your thoughts, right? So you think you're no good, so then you feel no good, so then you try and do something to make yourself feel good. It doesn't work, so then you still think you're no good, and we just go around, right? Until we do an intervention. Existential, right, is about meaning, and Frankl also brings in your values. He doesn't explicitly say that. That's what he is describing, though. Finding value in your life. And that pain and suffering are normal aspects of the human experience, right? And Frankl is definitely somebody who can speak to that, right? That pain is inevitable, but suffering is optional. And so what we take away from this is that things might go wrong. Now that's like a really big oversimplification for existentialism, but there is the acknowledgement that yes, things might not go the way we want them to. And then we focus on meaning like that. In fact, there's a book, very good, but things might go terribly, horribly wrong, right? If you really like that, I really recommend it. It's a good book for clinicians, it's a good book for clients, right? It's a good book for us as individuals. So, CBT and ACT. CBT, we're focusing on those cognitive distortions, the negative core belief, and changing the thought, right? So I had a client early on in my career, and it was kind of that textbook case of, I have to make $1 million or I'm a failure, right? I have to make $1 million for my family or I let them down. Where did that thought come from? And why do you think money is tied to success or failure? And there's other definitions of success, right? And so trying to change that. With that, we're still identifying thoughts and feelings, but we're changing the relationship with the relationship to the thought, my typo, but we're changing the relationship. We're not trying to change the thought, right? So we're not getting bogged down in challenging it. These don't have to be mutually exclusive. So those of you thinking, but why? What if there really is a conflict? Those things happen, and you are absolutely able to kind of integrate these together if you like. In fact, there probably are instances where a client has a cognitive distortion and a dysfunctional relationship with that or another thought. But the underlying premise here, what really the split difference between these two is that at no point with ACT are we trying to change the thought. We're trying to change what we do with the thought. There was another ACT author, I like how he put it, and I'll have to look up who it was, said it's kind of like with energy in Einstein. I'm not a science person, but you can't create or destroy matter, right? It's just there. And this person said it's the same with our thoughts. Once it's there, it's there. You can't get rid of it, right? You can't remove it, but you can change it, right? You can change what you do with it, right? It's there. And so that thought of I'm a failure, I'm not good enough, I'm not fitting in, might always be there, but we can change your relationship and how you respond to that. And I thought that was really powerful. Any questions so far? That was kind of a brief history. All right, so the goals, pretty simple, right? It's like Tetris. easy to learn, very difficult to master. Right? To live a rich and meaningful life while accepting the pain that comes with it. Right? And it's like, that sounds very good, very altruistic, very lofty. When we break it down, because the next question is how do we do this, is we focus on the acceptance of unwanted private experiences, another key term here. And we take committed action towards living a valuable life. And so this is one that's very introspective, right? So what are private experiences? They are both the internal chatter that you have in your mind and your emotional experiences. They are private to you. They're yours, right? And unless you share them, oh my God, my format is on. So the internal chatter is the thoughts. They can be painful memories, worries about the future. And your emotional experiences can just be the negative feelings or discomfort. And usually what I recommend with clients is to use the word discomfort, because you can spend a lot of time trying to precisely dial in the name of the emotion. And there is a purpose to that, and you should do it, but you should do it later. Right? At first, when we can't quite put our finger on it, the word discomfort will do. Right? You feel something, right? You feel anxiety, anger, fear, sadness, shame, but they might not have that language yet. They might not identify. So we say discomfort. And when we give into those private experiences, it leads to avoidance. I want to avoid these negative private experiences. I don't want to think about the time I tripped and fell in front of all my peers. I don't want to think about the time that I messed up my PowerPoint presentation. I don't want to think about this, that, or the other thing. And so I'll take steps away from it. So how many of you have gotten a text and then not replied, and then you kept not replying because you haven't replied and some time has passed? You know what I mean? Yeah. And thanks for being brave, being vulnerable, authentic, iconic. Yeah, and so that's what we're avoiding, right? I have to text now, like I know it's been like a week since you asked, you want to go get coffee, and now I'm replying to you, right? And that's uncomfortable. So what I'll do is I'll just keep putting it off. But what happens when I keep putting it off? Yeah, it might keep feeling worse. The relationship might change. I don't want to study the topics that are really difficult for me. I get frustrated. I feel like I can't do it, so I don't. In fact, maybe I'll go study, like you're getting ready for comps, your NCE, and you go and you keep studying the stuff you already know, because that makes you feel good a little bit. So you're like, oh, I was right. Yeah, you were right, because you read the chapter like 9 times. Right? Focus on the stuff you haven't read. And so we keep avoiding what makes us uncomfortable. The person with social anxiety, whether it's clinical or just kind of the subclinical kind, there's a call, I guarantee you there's a college student who is alone, is lonely, experiencing isolation, would love to join a club, join an organization, but he won't go. He won't go to the meetings, he won't introduce himself. Why not? Fear of rejection is a great. I'm afraid they're going to say no. I'm afraid I'm putting my mouth. I'm afraid I'm going to embarrass myself. So he keeps avoiding joining. By avoiding, no, he doesn't experience the rejection, but what does he continue to experience? Yeah, the loneliness and the isolation. And then before he knows it, college will have passed. And he will always remember, I didn't do anything in college. I never joined an organization I really wanted to. And so avoiding, do I need to?
No, I think it'll be fine.
So avoidance is the problem. So what do we do with all this negative experience? Well, the goal is psychological flexibility, right? That is another key term. And so if you needed a reduced explanation of the goals for ACT, it is to increase or improve or establish psychological flexibility. And that is the ability to hold to hold and manage uncomfortable experiences. And so when we talk about negative experiences, this is the existential part, right? Things are going to go wrong. Nobody has the perfect life, right? Something will just go wrong. It might be a small thing, it might be a really big thing. And so they have what's called clean discomfort, which I picked a nice picture for of soap. And then I Googled dirty dishes and it was super gross. So I went with clip art. So clean discomfort is the normal stuff. It's the stress of having an exam. It's the frustration of being stuck in traffic. It's the hurt, anger, fear when you didn't get the thing you wanted. These are things that happen. And dirty discomfort is when we start really chastising and ruminating and then feeling bad for feeling bad, right? So there might be somebody who is just having a down day, right? And they're feeling bad, maybe they've got depression, maybe it's just they're just in a funk. And they're saying, you know, I don't know why I feel this way. I don't have any reason to feel this way. So what's wrong with me that I feel this way? So now it's compounding, right? So it went from just, I'm not feeling great today to now I'm criticizing myself for not feeling great today. And it's just, it keeps stacking up. And that's kind of the suffering part, right? That's the part that we want to try to avoid. That's the part where it gets really messy really fast. You're allowed to have a bad day, right? You're allowed to have several bad days, right? That's normal. We would hope they wouldn't be very often, but if it happens, it should be no surprise. And that traditional CBT approach of like, what do you have to feel bad about? Go through your mental checklist, see everything's good. You don't need to feel that way, right? For some people, that works really well, right? For other people, it's like, yeah, you're right, but I still feel bad. I don't know what to do with that. And that's where we turn to ACT, where it's like, okay, well, if you're going to feel that way, let's find a better way of having that feeling. So Russ Harris came up with the idea of the struggle switch, right? Then I was like, we can modernize it. And so when you experience anxiety or discomfort, again, it can be any negative feeling or thought. When your struggle switch turns on, you start feeling bad for feeling bad. Why am I not over it? Why am I not over my ex yet? Right? When am I going to get it right? I always do this. I have nothing to be upset about. And we start doing self-defeating behaviors, right? Whether that be, I'm not going to go, you spend time ruminating and you waste your own time, right? Or you choose to spend your time ruminating. You self-soothe with drugs or alcohol or other unhealthy behaviors, or you just don't engage in the stuff that you want to. Or you just stare into the void. Right? Anybody else just kind of sit on the edge of the bed? This is happening, right? This is the day. Now, when we turn the struggle switch off, or if we keep it off, we acknowledge that discomfort, right? And that can be difficult. You know, it's kind of like having a muscle that you've not used. But acknowledging, yeah, I'm feeling kind of insecure. I'm feeling down. I'm feeling angry. I am thinking about this argument I had last week. Some of you are thinking about arguments from like 4 years ago. I can have that discomfort and still invest my time and energy in what I want. I can have that feeling and still move in a valued direction. And I'm willing to experience the discomfort that comes with pursuing my goals. So for y'all going to grad school, right, is an endeavor y'all have chosen to do. You're doing it to further your education, pursue a career. And it comes with its set of challenges, right? There's group work and presentations and schedules and tests and financial aid. There's all-nighters, there's dissertations. And so, but you put up with that discomfort in pursuit of this goal, in pursuit of this value that you have. You are willing to do that. You are willing to rearrange what you need to rearrange to make this happen. Some of you I know work full time, And so you have class on top of work, and some of you have class and work and families, and not that it's like a tally, everybody has different responsibilities, but you think that this is what you want to do and you're pursuing it, and you're willing to put up with the discomfort that comes with it. And when we do that, when we just kind of acknowledge it, this goes back to Megan's example, when we kind of acknowledge it and we don't try and fight it, we don't try ignoring it, it moves around. And sometimes it'll just pass. You know, give it a couple minutes and it'll go. Take a deep breath. Has anybody kind of ranted or you're venting to somebody? And at some point there's a pause in the conversation and you do one of these. I guess it's not that big, right? You cool off. You feel it's very Kendall-centric day. Yeah, so like taking that breath. Sometimes it's just a matter of time and it goes and you just wait it out, almost like having a cramp, right? You're not going to talk it out. It's just going to work itself out. And for other people, that discomfort will grow, right? And that is one of the things when we get to it, when we talk about mindfulness practices, is that we're educating clients about what can happen. And then it'd be interesting to hear your experience with clients. But whenever I've done mindfulness stuff with clients, I always kind of I started getting really angry and I couldn't stop thinking about whatever the problem was. And that's normal because you're not distracting yourself with whatever, right? Some of you probably throw yourself into your work or your studies or, you know, what arts and crafts or whatever. And that kind of keeps the discomfort down. But when you're not distracting yourself, it kind of rises up, right? And it's there. And that's where we have a choice of either kind of activating the struggle switch and getting really upset or acknowledging, okay, maybe I'm not quite as over this as I thought, right? So when I was in grad school, I had a really close friend who was like, oh, I'm Mr. Chill, nothing gets under my skin, right? And then one day something got under his skin and I was like all over that. And I think he was traveling and we went to drop his dog off at the vet for boarding. And they canceled his reservation at the last minute and they're like kind of jerks to him. And he was like, well, you see, Chris, I'm not letting it bother me, right? You should be like me and chill. And, you know, it's like 4 days later and we're still talking about it. You know, that's all we talked about. And eventually he did say, you know, I guess maybe it did bother me. And it's like, oh, maybe, you know, and so what are we going to do with it? And so it's not to dispute the veracity or the authenticity of the thought, but it is to change what we do with it. Let me stop. Questions, thoughts, reactions? Yeah, Nora.
I guess two just clarifying questions. So is the assumption in Act 2 though that like the goals you're working towards should be in line with the values of your life?
Yes.
Okay.
Yeah.
And you just like inherently know that? Or
No, one of the first things, and John brought this up at the beginning, like we would do, and when we get to the case, one of the first things I do is a value assessment to try and figure out what do you want to do, like what's important to you, and I have some examples on here of what that assessment looks like and what steps do you take to do that. So we are doing that, and we let them tell us their values, and that serves as the compass for where we're going to go.
Okay. And then my second clarifying question is the difference between mindfulness and distraction just your ability to come back to the moment?
So what if instead of distraction, we said mindlessness, right? And so mindfulness is the intentional focusing of the present moment and without judgment. And distraction would just kind of be you're all over the place, or mindlessness would be the experience of when you drive home and like you don't remember anything between leaving this lot and getting home, right? You just sort of autopiloted there. So that's mindlessness, or eating a bag of chips and before you know it, it's gone, right? And so I guess to your point, mindfulness would be the intentional focusing on the present moment or whatever it is that you're choosing to focus on. For some people, it's really difficult to just focus on the moment. And so I've done stuff where it's like, let's listen to this sound, or like I used to have an office with that was near a garden. And so if I open the window, we could hear birds, and it's like, let's just see how many different types of bird chirps we can hear. That's still mindful. You're being mindful of the bird chirps, right? But it's the intentional focusing it's a directed focus of one thing without judgment. Does that kind of answer your question?
Mhm.
Kendall?
I just didn't know who would have.
Yeah.
I did send it.
Mhm. Mr. Bird?
So during mindfulness, are you trying to not focus on other issues, or are you trying to bring the issues, or are you just trying to see what comes up?
In that moment, I use mindfulness to kind of, help regulate emotions and thoughts, right? So when somebody's feeling really overwhelmed, it's like, let's ground ourselves, let's take some deep breaths and just kind of notice. And it's to stop all the chatter and the movement in your head. And usually at the end, because I'll usually open a session with like, let's do like a couple deep breaths. And yes, ideally, if everything went perfectly, they're just focusing on their breathing in the moment. And usually, but stuff usually comes up because we're all human. And then in session, you can choose to focus on those things or not, but it is to help them I see it as we're helping them learn how to control the thoughts and feelings and kind of without getting overwhelmed. Yeah, exactly. That's a great way of putting it, slowing it down. Yeah. Tell me, did you have a question?
No, I guess maybe I didn't end up, but I definitely practice mindfulness quite a bit. And it's like muscle memory. Think of feeling like a thermometer. So if your client comes in, your feelings kind of stack up. And there's at this point where mindfulness comes in as a resiliency mechanism. So if you're a little bit overwhelmed, it can be really beneficial, especially if you're not impactful later on.
Yeah. Yeah, it's a good skill, and it's really good for people who are maybe prone to, if not panic, just really intense anxiety, right? Because when you're doing that deep breathing, right, and you put pressure in your belly on your vagal nerve, it deactivates the alarm, right? It says, hey, we're safe. Like if we weren't safe, we wouldn't be able to take this long, deep belly breath, right? We'd be breathing up here, which signals I need to move, I got to get out of here, right? And so when someone comes in, such as the client I told you about before who missed graduation, she was one of the last things she said is, if you open this window, I'll jump out, right? And so cooling down, like, hey, we got to turn off the alarm. And so mindfulness kind of helps de-escalate and organize. And then over time, has a longer term effect of being able to kind of organize thoughts. And this probably isn't the best way to describe it, managing the flow of what goes through your mind. Yeah, please.
What about in environments where, let's say, somebody else activates that, like let's say it's a child that has activating all of those negative thoughts, like,
yeah,
I have nothing to be upset about. Like, how do you go about kind of teaching the child to be mindful in an environment where perhaps it's not being supported in the way that it should be?
So like when there are reasons to feel that way, yeah. So, and that's a great question. There's lots of different ways to practice mindfulness, right? The most traditional way is that like stop and breathe, but you're not always going to be able to do that. And that's where we try to focus on these. And it's really important that all of you have, if you're going to do mindfulness things, you have multiple ways of explaining it and different tools to give clients. So in this case, it might be, and this is going to sound super cliche, like kind of a on the nose response, but like, can you find a quiet place? And the answer might be no. I got an annoying sibling, they're always following me around, I can't take a moment, or I'm always on edge. So then it becomes, well, can you do grounding, right? Can you wash your hands, right? Can you just feel the water going over your hands? Can you feel like the slickness of the soap? Can you smell the soap? And all of those are different acts of mindfulness. Yes, some are probably more efficacious than others, but that you highlight this really important thing that not everybody has the ability to carve out even 10 minutes just for themselves, right? And so there are other ways to do that, and there will continue to be other ways, and you'll work with clients to find creative ways of doing it. But it can even be things like, can you, when you listen to music, just listen to the lyrics? Like, how many of you have put on your actual favorite song, but then didn't even listen to it? So then you repeat it, right? Can you listen to, I've had clients where I've said, can you just listen to the bass line? Can you listen to the drum? Can you find a place and can you go in your backyard and there's an ant hill? Can you just sort of watch the ants? Watch them come and go like in their little circuit, right? Because it might be the only thing we can get out of it is maybe a minute or two there, but it's still growing that muscle to practice it, right? And if we can get them to say, I did it and I felt a little bit better, wish I had more time, then we're moving in the right direction. Yeah, great question. This is an important question too. Other questions? Everything making sense so far? Let me check in. Yeah. Questions? Okay, so now we're gonna get into the meat now, right? So these are the 6 processes. And we'll go through each of them, right? The present moment, values, committed action, self is context, cognitive fusion, and acceptance. This is the hexaflex. And this is what you'll find if you Google ACT or acceptance and commitment therapy. And each of those processes interacts with the other 5. And when all of them are in line, when all of them are working, we will achieve psychological flexibility. The ability to hold or manage or move in a valued direction despite discomfort. This is the inflexa hex, and this is the opposite, right? When you don't have psychological flexibility, this is what we have. So let's start with, what is the problem? Inflexible attention. Here, what's meant is the person is really focused on the past, so you're ruminating, or you're worried about the future. You keep thinking about what's going to happen, but you're not here and now, right? And if you're not here and now, you can't take any action, any valued action, because you're living in the past or thinking about the future. You're not aware of how you're feeling because your mind is elsewhere. Lack of values. I shouldn't say lack of values. It's really more that they're opaque or they're covered, right? They're not clear. There's a lack of clarity. Or the person is like really fused, for lack of a word. They're going to stick to, I must have these values. This is what, think of like toxic masculinity. This is what a man is supposed to do, right? This is what I'm supposed to do. And if you don't have identified values, it's really difficult to know what direction to go in, which I think, Nora, was the point of your question, and for Jalen, that was the point of doing an assessment for values at the beginning. So we know what's important to the client. We're not saying this is what should be important to you, but this helps us give a direction. This is especially important, and I'll go over how to do this, when clients come in and they have kind of the theme of, what brings you in? I don't know, I'm just feeling kind of stuck. I don't know, I just don't feel right. Something just feels off. Inaction, impulsivity, or avoidant persistence, right? So not taking steps. So the person who maybe has a social anxiety, I really want to get involved. There's a gaming club and I love gaming and I want to join, or I want to try and go to the gym and I want to get fit and I want to do that. But I don't, right? I don't do that. I say I want to, I value my faith, my spirituality, but I don't go to church. And maybe I'm in a new area and I don't know the church for my particular faith, but I'm not even taking steps to locate one, right? And so we're not doing that, or we're doing behavior that's just like inconsistent. It's all over the place. This one is one of the more complicated ones, but attachment to the conceptualized self is you have a thought about yourself and you act as though it's true. I'm a loser. So that's it. Like I am a loser. That's who I am, and I do loser things. And I'll stay home. So the person who wants to join a club but doesn't, they're afraid they're gonna call me a loser because I was called a loser before. I think I'm a loser. Who'd want to be friends with me? Then we'll start to act that way, right? I am a loser. Why would they? It's just an accepted fact. Cognitive fusion getting tangled in the thoughts, and these two have a really strong relationship, because if you keep having the thought, nobody loves me, nobody likes me, I'm worthless, I'm a loser, that feeds into this one. And so I'm not able to distance myself from those thoughts. Those thoughts are in control of my life versus me being in control of the thoughts. And I couldn't think of a different word for avoidance. So experiential avoidance is avoiding, right? So this is me trying to avoid, I guess I could have said control would work, trying to control or avoid negative experiences. So I don't want to be rejected, so I'm not even going to try. I don't want people to make fun of me at the gym, so I'm not going to go, right? I don't want to think about what my partner said to me, so I'm going to pretend like it never happened. Right? So this is the part that we do want, right? And they're all the opposites. So they're all the opposites. I'm going to walk you through each of these, and I'm kind of going in the order that I typically go in with clients. You don't have to go in any particular order, though I do think there are clients who come in and one of these is stronger or weaker than the others, and that kind of gives you a guide. But I will typically start with values. So values versus confusion. This is not the same as goals. We are not talking about what do you want to achieve or master. Values is a direction, or a value is a direction. It's like saying, it's the difference between saying, I want to go to New York, which is a destination, it's a goal, versus I want to go north, which is a direction, right? I'm moving in the direction. You never really get north, right? Because you can always go more north, I guess, until you get to the North Pole, right? Or going west, you can always go west, right? Values are broad, overarching ideas and concepts that the client moves towards. So I value the importance of family. I value health, right? I value my relationship. I value my education. And so you take steps towards those versus I want to get an A, versus I want to be in a relationship, versus I want, to lose 5 pounds, right? They're longer term goals that you are kind of always going to move in the direction of. And this is also the opportunity to explore cultural factors, right? Not all values are going to be, they're not going to be ubiquitous across culture, right? And so this is a good opportunity, especially if you're kind of giving a standardized assessment, to invite that conversation about what's important based on different cultural contexts. And again, culture is not just race and ethnicity, right? There's a whole bunch of other factors to consider. Some of the techniques to work and improve this process is the value assessment, which I'll show you in a little bit, and giving homework, right? Monitoring, continuing to expand on that, right? To help them clarify. That's really the goal, is to clarify values. And then I move to action, because let's say they do have values. They have them spot on. They're real confident about them. Are you taking steps towards those values? Are you living according to those values, right? So you say you value education, but you skip all your classes. You say you value family, and and this is not how you say it to the client, right? I'm saying this to you. You say you value family, but you never spend time with them, right? You value independence, and yet you seek everybody's approval. And so, are you taking the steps, and are they functioning? Are they functional steps, right? Because someone might say, yeah, I do that, but yeah, I value education, so I skip all my classes, but I study. 6 of one, half dozen of the other, right? And so instead of action, are they avoiding or acting impulsively? And some of the things that we do for action, and there's, as with everything else, there's an assessment for this too. but we're exploring, you know, if you're not taking steps or they're not consistent, why not? And the act assumption would be it has something to do with avoidance, right? Especially if avoidance of discomfort, especially if they have established goals. And so then we kind of challenge them to do something small that'll make you uncomfortable, right? Take a cold shower, right? Like really small, right? Take a cold shower just because you can, to show that, look, I was able to do that, right? I value improving my life. The counselor said to do this and I trust him, so I'm going to follow his advice, and I'm going to try and do something I'm uncomfortable with. And that is, I'm going to maybe not go to the group on campus, but maybe I'll join a Facebook group, a local Facebook group, right? But here what we're trying to do is have them get familiar with the experience of taking action. And then you would further discuss it. And then contact with the present moment. This is where all the mindfulness stuff comes in, right? What are you feeling here and now? Not ruminating, not worrying. So I have a client who he has kind of a newer term, retroactive jealousy, right? So he's in a relationship, but he cannot get over that his partner had a life before him. And how dare she? And he'll really kind of dig into her and kind of shame her for whatever past romantic experiences that she's had. And he's so focused on that, but not focusing on how he feels, which is he feels very insecure. And what if I'm not good enough? What if I'm not man enough? What if she doesn't really like me or love me or whatever? He keeps thinking about the times that he was slighted in the past, and he can't move forward, and it's taking away because he's pissed off all the time. He keeps thinking about how he's been wronged, and then he carries that anger and frustration into his current interactions. So he's not here today because he's living in these past experiences and these past emotions. So part of the present moment is not only to escape that, but it's also to identify what are you really struggling with. And to Sabrina, to your question earlier, if we're doing it and he's saying, you know, I really am still struggling with this thing that so-and-so said to me, well, then maybe we should address that, right? These three, the awareness techniques, grounding, right? What are 5 things you see, 4 things you hear? The meditation and all of its very many ways. Dropping anchor, I'm here right now, I'm acknowledging my experience. But it's really important that you explain mindfulness, right? It is not, hey, just take a deep breath, right? Be here now. It's difficult. I've never had a client who immediately took to it, right? There's always some discomfort, and it's usually in the vein of, well, I just keep thinking about the thing. And it's like, yeah, I know, that's part of it. We gotta keep practicing, right? These 3 things together form the commitment and behavior change process. This is the action part. This is the behavior part. Diffusion and fusion, right? So when we're fused to our thoughts, they're running the show. Our thoughts are front and center. We're caught up in them, and we just believe them. I thought it, so it must be true, right? And if we do things the right way, we diffuse, and we work on diffusion, the person's able to step back and realize I'm having the thought, right? So instead of saying, I can't believe that guy said that to me, I'm remembering the time that I got really upset. I'm remembering a time this person hurt me. That's what's on my mind. And there's a little bit of, and this is the CBT part, challenging some of those thoughts, or if we need to stay with them. So for example, what's at the end of a rainbow? Get it, Sabrina, you know this answer. The pot of gold, right? How many of you have pursued the end of the rainbow? Nora, Price, I figured, right? But you don't do that because you know that, right? Like, hopefully I'm not spoiling anything. There is no pot of gold, right? We don't go and do that. even though we know the thought, right? In fact, I'm gonna pick on Sabrina for a second. When I said, what's at the end of the rainbow, this big smile, I got this one. She knows that she's ready, right? Because it's an automatic thought. It's an automatic thought that she had, pot of gold. She doesn't act on it. She doesn't see a rainbow. I'm making an assumption. You don't see a rainbow and you're like, there's gold, right? So let's take it a step further. And you go to a class, you get a group assignment, and now there's a group of students you've never worked with. You got to introduce yourself. And your immediate automatic thought is they're not going to like me. You were conditioned to have that thought. It didn't come out of nowhere, right? Maybe it was you really truly had a negative experience. Maybe you saw somebody else have a negative experience. Maybe somebody said something. But you're in the situation and a thought pops up automatically. So the same way we see a rainbow and we don't say, huh, let's go find some gold, right? We're able to recognize that's a thought, but it's not an accurate thought. It's not a true thought. It's not a realistic thought. We don't always do that with our own thoughts, right? Or thoughts about ourselves. So the idea of I'm going to introduce myself and they're not going to like me. I just accept that as true, right? Instead of, yeah, I get that thought. I don't have to believe it though. Does that make sense? And so when we then, hopefully you're kind of seeing how these things tie together. If we can stay in the present moment, right? So I'll pick on Price. Price has to work with a new group and he gets really anxious and he maybe starts kind of fumbling around and he seems nervous. He's definitely not feeling good. Without any of this, he just kind of goes and he's meek and mild and kind of, or maybe he's going to go in the other direction and be very boisterous and like, look at me, I'm so great, accept me. If we practice mindfulness, or after he practices mindfulness enough, he might be able to say, okay, I'm having a moment. What is this about? Let me chill. I'm uncomfortable because I have to go introduce myself and I'm worrying that they won't like me. What do I want to do with this? Do I want to go in and be nervous? Do I want to go in and be arrogant? Or can I maybe set that thought aside or acknowledge and say, yeah, there's that thought. And I'm going to go introduce myself to this group and try and put my best foot forward. Right. And so that's, if we have mindfulness, we practice that, he can identify the thought. And if he can identify the thought, he can step back from it. He doesn't have to obey it, for lack of a better word. Thoughts, questions? So some of the techniques for this is the part where I feel like I'm working the hardest with clients because it takes right? I'm not alone in this. Like, it takes vulnerability on our part for some of these things. So unhooking, right? Unhooking from your thoughts and your experiences. And part of it, and personally, you know, I'll be vulnerable. What works for me is just thank your brain, right? It's trying to protect you. So, and Price, this fictitious example, because everybody loves Price. So Price, he gets nervous and he acknowledges, okay, I'm having the thought, I'm going to be rejected, I'm not going to be accepted, nobody likes me. Doesn't mean it's true. Just because I'm thinking it doesn't make it true. But it is my brain's attempt at protecting me from feeling shame. Right? It's just trying to protect me. It's doing it in a really inefficient, awful way, but it is trying to protect me so I don't get hurt. And so what Price does is he acknowledges it. I'm having a thought, and he thanks the brain. Thank you, brain. I hear you. Thank you. I get it. You think I'm going to get hurt? I appreciate it. Thank you. Right? So acknowledging it. Saying it out loud. Remember when you were children, you said a word over and over and over again? What happens? It loses its meaning, right? So someone calls me a loser. Loser, 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 until it starts losing its meaning, right? And that, you can see that's that influence from those linguistic theories. But the one that I think is really strong, that is really difficult, is to like sing it, right? Which is what Russ Harris says to do, right? And so if like someone calls you a loser, it's like, you know, sing it to the tune of Happy Birthday. Loser, loser, loser. That's, you get it. So that's the extent of my discomfort. And so doing that to kind of de-power That's how I explain it to clients, is it's depowering that thought, right? Look how it's big and scary when you're thinking it. So Price is afraid of rejection. And in that thought, it is scary, but when he kind of acknowledges it, makes it lose its meaning, makes it silly, it's not as scary. And again, the goal is not to go from 10 to 0. It's to go from like 10 to functional, right? Which Price might only need to go down to 8 for him to like, okay, I can do this. It's uncomfortable, but I can do it, right? And that's a great place to be. Helping them understand the role of the brain, right, that is trying to protect you, not always in the best way, but that is what it is, versus like, what's wrong with me? I can't stop thinking this way. Self is context. So this is the observing self. You are not your experiences. So maybe someone really does hurt you, right? And that happens, right? We said pain and suffering happens. You are rejected, you are hurt, you are betrayed. Someone calls you a mean name, and it hurts. But you don't stay in that forever, right? The opposite of this is, I thought it must be true. I'm a loser. Why else would I think that, right? Instead, we're asking the person to kind of think about it as, you are the thing through which thoughts occur, right? And that's kind of a heady thing. So some of the ways to kind of demonstrate this, some of the techniques is, think of the sky, right? We have a sky, and when it's storming outside, right? It's cloudy, it's lightning, it's thunder, it's rain. The sky doesn't change, right? The sky is the sky. The weather occurs in the sky, right? For little kids, like Dominique, you're working with kiddos, would be, think of a pond with fish in it. And each fish is a different thought or emotion. You are the pond. You are the thing through which these thoughts and emotions exist. You are not one of the fish. You are not your anger. You are not your sadness. You are the thing through which they occur. And so so once we kind of explain that, because then the next question we have for the client is, so knowing that, what do you want to do? Now that you're not locked in to doing whatever these thoughts dictated for you, some of the things are having them write a script, a movie, right? So I want you to write about your life, or I want you to finish this story. Price just got a new group assignment. He has to go introduce himself to new people. He's really nervous about that. Now, Price, I want you to finish what happens in that story. I want you to write it down. You might say, if you were to make a movie and you're the director and you're directing the person who's acting as you, what would you have them do? And so Price might say, well, I'd have him go up and just be super nice, and he'd know all the right things to say, and he wouldn't be nervous. And it's like, okay, let's try and get you to be that, right? Let's try and get you to take that action, right? But we're separating these thoughts of what we are and just kind of realizing that there's me, and then there are the thoughts I'm having. So again, you can see that really strong relationship with diffusion. And finally, acceptance, the big one, it's in the name. And you can think about it in terms of levels, right? At its very surface, it's acknowledgement. I acknowledge that this is how I realize this is difficult. I realize that this is uncomfortable. Acknowledgement, though, isn't always quite enough. In fact, at a conference I was at, I was talking about ACT, and I said, I didn't get to finish my sentence. And I was like, acceptance and acknowledgement. And somebody was like, I don't think that's sufficient. It's like, I know, Deborah. Acknowledging is one thing, but willingness, and there are some of you that have had me in multiple classes, and I apologize because you're going to hear the example again. Swapping out acceptance for the word willingness, right? So if I said, going to grad school is going to be very difficult. It's going to be very time consuming. You're going to feel very vulnerable. It's not going to always be exactly what you want. Are you accepting of that? Do you accept that? Now, if we switch it to grad school is not going to be everything you want. It's going to be difficult, and at times you're going to feel very overwhelmed. Are you willing to experience that in pursuit of your goals, right? It's a willingness. I realize what it's going to be, and it's accurate, right? Not a distortion. It's going to be the worst experience ever, and there's probably room to say, what if it was? But are you willing to do this? In couples counseling, right? Every Hallmark movie that has ever existed revolves around the premise of, I'm afraid to love, right? And in real life, there are people who do that, who they're okay dating and being in a relationship up to a point, but they really want that connection. They really want to be in a romantic relationship. So are you willing to be uncomfortable in order to be in this relationship, right? And when I work with couples where one person is like, look, I need my partner to open up, I need them to give me more. And that reluctant partner is like, well, I'm afraid, right? Like, I don't want to do that. I don't want to be vulnerable. I don't want to give that, but I really love my partner. And it's like, well, are you willing to be uncomfortable for the sake of your relationship, right? And again, to Nora's point, we're not telling them there is no right answer. Like, they could say no, right? Like, I value my safety more than I value this relationship. It'd be super awkward in that session, but they, that is a value. They value their safety more than they value that connection. Then probably what I consider its highest level is reaching, right? Reaching for that discomfort. So it's one thing to acknowledge that I know it's going to be hard. It is hard, but I'm willing to do it. I'm going to try it. I really want to do this. I'm willing to put up with it. And reaching it is the same as kind of like welcoming it, right? I'm taking, and that is apparently the root part of the word acceptance, is to reach and to take, right? And so this is going to be difficult. And you say, okay, I'm going to take that difficult. I'm going to take that discomfort with this experience, right? So you're not just letting it passively happen to you. Now this is kind of, in my experience, this is kind of a theoretical, hypothetical place, right? Getting them to a place of like, yes, this is really difficult, but it's worth it. That's willingness. We'll take that. We can work with that. And I'll go over this thing in a little bit. One of the things that we do is called a choice point. And you come up to a choice, right? It's kind of like that cliche example. You come up to a path in the road, right? And you can move towards your values, or you can take action that moves you away. The assumption for ACT is that if you get hooked on your thoughts and negative experiences and the lack of values and fear and uncertainty and doubt and all of that stuff, you're going to make decisions that take you away. You're going to take steps away from what you want to do. And so what we do in homework that we give clients and what we go over in session is, so this moment came up in your relationship where it was an opportunity to show up for your partner. It was an opportunity to go ask for help. It was an opportunity to move in the direction of your values. Did you or did you not do that? And why? And we do this non-judgmentally, but if we can kind of unhook from all the discomfort and anxiety, in theory, they'll move towards it. And so that's what we do, because we would want them to think about a time when the student with social anxiety. What's the thing by the library where they have all the tables out? They're tabling, and they're recruiting members for organizations, and I could go, but I'm so scared, and I'm going to get embarrassed, and I don't want to do that. But they practice everything that we do in session, and so they're able to move forward. Doesn't mean that they enjoyed it, but they took steps towards their value versus I got overwhelmed, and I kind of listened to those thoughts, and I moved away, right?
So in ACT, is the most important thing the patient's willingness, even if there is no acceptance yet?
Well, willingness would imply that they have a degree of acceptance. Yeah.
But if they don't have anything, like they're still very kind of like they're just almost like suppressing the traumatic experience, would you still say that ACT is a good therapy modality for them, or would you try something different if they're still very reluctant towards accepting something like very traumatic?
So in that case, the acceptance part, the willingness part would be maybe more about when those thoughts and that discomfort comes up, what are you doing? Are you allowing those thoughts to exist and kind of move through you? Or are you self-soothing and avoiding and doing behaviors to try and control it and keep it away? Right, so the goal might be, are you willing to acknowledge, are you willing to experience that discomfort? Does that answer your question?
Yeah, so like almost making them aware of.
Yeah, so the goal in counseling then might simply be, I would imagine in that case, that client is gonna come in and say, my whatever kind of behavior, drinking, eating, relational behavior keeps getting in the way of what I wanna do. And as we kind of peel back everything, we'll see that when I have moments of thinking about my trauma, I immediately go to a place of self-soothing and escape. And that self-soothing and that escape keeps me from taking steps towards what's important to me. So that might be the goal, the ability to experience that discomfort. And then we kind of move towards, okay, so you can experience it. So now let's talk about what's important to you and what steps you want to take. So these together are the mindfulness and acceptance processes. So if you needed to break it into two, we kind of have this cognitive, internal, experiential one, and then we have a very outward behavioral section, right? In fact, we have, there are different conceptualizations of it. That's the most flavorful one. That's the biggest one, right? But one way of looking at it is be present and accepting, right? So we focus on diffusion, self as context and acceptance, and take committed behavior to values. Another way of looking at it is what's called the triflex, right? Where we say, open up, right? Diffuse from your thoughts, acceptance, be present, right? So be in the present moment, realize what's going on, you're having these thoughts, and do what matters. So there's different ways to kind of break these things apart to either A, conceptualize for yourself, or to help your client understand or conceptualize. And you do the one that is most efficient, most efficacious for you. If it's doing the full hexaflex, do that. If you need to kind of break it into two columns where it's like we're going to focus on being present and accepting, and then we're going to focus on committed behavior and values, do that. If it's somewhere in between, maybe do this. And there are other ones, right? Different counselors and clinicians have kind of broken them into different ways, and you can do that yourself, right? The way I explained it is the typical path I go with most clients, not all of them, and you will have your own. There's no one way to do it. So that was a lot. Let me check in. Questions, thoughts, concerns. I'll put the hexaflex back up as a reminder. Oh man, I have a handout too. Man, just throw them in the trash. One side has the hexaflex and one side has the inflex of hex.
You make copies for clients.
Yeah, maybe. Yeah.
It's so elusive.
It is. I do think it's like the most complicated one. And so, and then like if I'm off base, definitely like shut it down. So the reverse of it, self as content, is whatever you're thinking is what you are. And so if you think, I'm not gonna make the team, I'm not gonna get an A, I'm gonna fail, I'm a loser. That's it. You think those things are true. You are a loser, you are a failure, and so on. Self as context is saying, I'm Megan, I don't want to use you. I'm Chris. I'm having the thought that I'm a loser. I'm having a thought that maybe I'm a trauma survivor, and I have that mentality of like, I'm such a victim, right? I'm really blaming and shaming myself. I'm a victim. And so self is context is the thought is simply occurring in my head. It's not some universal truth. It's only occurring in front of me. It's something that I can read and I'm experiencing versus something I am.
When self as content is
there's ones that are more, for like whatever it's negative, like where you said, I am rooted. But then there's some that are just really supportive and helpful, but you develop these rules around it. It's like, for example, believing yourself to have all the wisdom and like mastery over this one single subject area, and you encounter an event where it's being challenged.
Yeah.
And so as a way to compensate, you focus more efforts on kind of proving to yourself that, hey, I am a genius, I am one when it comes to doing this field. How do you combat that? Because although it's disguised in a way, right?
Yeah, that said perfectly, it's disguised. So I'm dealing with perhaps the discomfort of I might be wrong, or there might be people who are smarter than me, by going to a place of I've never been wrong before, I'm not gonna be wrong now.
Yeah.
Right, I got it all. And so in counseling, because we would imagine that would probably show up as a problem like over arrogance or overconfidence, and realize in session, if they describe that, we might say, tell me more about that. Is that confidence, or is that protecting yourself? Yeah. And so that's where we say, remember, the whole thing is grounded in functional context. The person's having the thought for a reason. So you had said that maybe the person went and they were proven wrong, but you didn't know something, you made a mistake. And so now this overconfidence is there to keep them from ruminating on it, from thinking about it, and maybe to shake the thought of what if it happens again, right? So the function it serves is, I don't want to think about the shame of I made a mistake, or the discomfort that I made a mistake.
And so people like confusion back. It's interesting. This sounds like they're having one back.
Yeah, probably. It can go in a whole lot of different directions. And so you can start with, you are not your thoughts or who. The other term that they use for this, which I think would have been better, like, because it's my opinion that matters, is the observing self, right? Are you able to step back and observe yourself having that experience and having that thought? And so if it's me and I embarrassed myself, I give a presentation on ACT and I get it all wrong. And I feel like I'm a failure, I'm a joke. Can I, in my head, can I kind of separate, can I set up a process where I'm observing myself experience that shame and that doubt and that fear versus just experiencing it myself?
Like taking on that burden.
Yeah. Yeah. Can I see myself experiencing shame? Can I see myself worrying? Can I see myself doing what I would hope I would do? Can I see myself doing those things? And so, and they have scripts that you can download from us, all of these. One of the scripts for this is kind of along the lines of, well, Megan, can you, sit and close your eyes, and we might do some grounding stuff. Can you envision yourself experiencing these thoughts? I don't want you to literally experience them. I want you to imagine yourself. Can you kind of, in your mind's eye, see yourself like you're watching a movie of yourself experiencing these thoughts, right? And so that's separating, there's Megan experiencing it, or like having the thoughts and the feelings, and then there's Megan that actually experiences it. As we distance it, then it's easier to achieve this, and vice versa. Yeah.
I'll add on to that, because selfless context is probably one of the harder things to explain in the Hexaplex model. So like speaking on the observing self, and you can use different kinds of questionings or worksheets and other things, but like something that could be helpful is asking the question, just what has been you your entire life? What has been the thing that witnesses all of your thoughts, feelings, and actions and experiences? Can we go there for a second? And it's tied into diffusion, it's tied into contact with the present moment, and just getting them in touch with the essential observing self that is like the sky, that all things move through, and then also there's another aspect to it where we're not our roles that we find ourselves undertaking in life. So like, you might have a client, I've had a client that's come in and they just retired. Now they, you know, that's connected with values and committed action. I don't know what to do with my life. You know, I was a police officer for this amount of years. I don't know who I am anymore, you know, and still using that observing self with that, you know, you were, and I won't say, may not say it like this, but you were never the police officer. You were just a person who, you know, did policing, you know, and our roles change all the time, but you're the person who fulfills those roles. You're not the roles themselves. So that one is kind of difficult, but there's a lot of ways to kind of go about it.
Yeah, thank you. That made a lot of sense. One of the things I want to add on is when people are avoiding, let's go back to I was thinking about this last night as I was kind of like getting ready for today. The person who avoids applying for something, right? I want to go to grad school, I want to go to law school, I want to go wherever, but what if I don't get in, right? And when you think about it, if you apply to something and you get rejected, or you ask somebody out on a date and they say no, or you try out for some club and don't get in, the result is the same as you not trying in the first place, right? Rejection, no, you're still exactly where you are. So what does that tell us? The fear is really not the rejection or not getting in or fear of failure. I'm avoiding the feelings that come with it. Because you're like somebody who really wants connection. They really want to be in a relationship, but they're afraid to interact with people. They'll come and they're going to say to you, what if they say no? What if I embarrass myself? What if it doesn't work? And it's like, well, you're no better off in that situation than you are now. You are still alone. What they're kind of saying, or what we would go to, the place we would go to, is that you are trying to avoid those negative feelings of I wasn't enough, right? So it's not about getting in. It's about, what if I can't handle that feeling? What if I can't handle the feeling of rejection? What if I can't handle the feeling of shame? What if I can't handle the feeling of vulnerability? And so to avoid that feeling, those negative feelings, I don't take steps towards the thing I want to do, right? So somebody wants to apply for an award, and they don't, because like, well, maybe I won't get picked, or what if I don't get picked? The issue isn't whether or not they'll get the award. The issue is that they're afraid of the feeling that's going to come with it. It's fear of, I won't be able to handle not getting that award. The award itself is just sort of the storyline, the plot device about explaining how I need to avoid feelings of rejection, right? And this can apply to anything. Maybe it's not rejection, right? I don't want to open up to people because, you know, I think they're too clingy, or they need something. And there are clingy people. And it might be that I don't like the idea of being vulnerable with somebody. I can't handle that. So instead of saying, I don't like being vulnerable, or I'm scared to be vulnerable, what I'll say is, I'm not looking for anything serious, right? I'm one of those people, I'm never going to settle down. And, you know, and there are people who are like that. They're not the ones that are going to come to your session and talk about it, right? They're out doing what they want to do, right? So a lot of it is not usually about whatever surface level goal, which is why we focus on values, right? And so when someone doesn't get what they want, like, so I'll share an experience. There was a job years ago that I really wanted, and I had worked for years to get it. And everybody told me I was going to get it, and it didn't happen. And I was furious, just more angry, I think, than I've ever been in my life. And I felt very betrayed. And it wasn't about the job, where I kept saying, you know, it should have been mine. And it wasn't about the job. It was the fact that I felt like I had made myself vulnerable, and I had really worked towards something. And these feelings of I wasn't good enough came up. Now, did I say that to anybody? No, of course not. What I said was, I'm pissed off because I didn't get the job and it should have been mine. Inside, what I felt was complete rejection and self-doubt, right? And so it wasn't about the job, right? My difficulty during that time in my life was not because I didn't get a promotion. It was because it was a time where I really thought something was going to happen, and I really leaned into it, and it didn't. And it just kind of shook me, right? Because it's like, whoa, that was me at my best, and it didn't happen. What does that mean about me, right? And it took a while to kind of get to that place because one, I was legitimately angry, right? Two things can be true, the feelings of vulnerability and the feelings of anger. In the end, though, I really struggled with that. I really dwelled for a long time on it. And it wasn't so much about the job because it was like, well, I could go get a job. I could get that same position somewhere else, right? Why not do that? I could get more money, right? Because it would have come with a raise. I can go get this other job that has more money because it wasn't about the job. It was about how not getting that made me feel. And it was a really ugly feeling. It was a normal feeling. I know that now. At the time, though, and you've all have probably had experiences where you feel like you are the only person that has felt that, right? So same thing, like, and so some people will protect themselves and say, well, I just won't apply for the job, right? You can't get rejected if you don't, yeah. You know, and so you can't lose if you never get in the game. And that's what people will do because it's not about, will I get the award? Will I get the job? Will she say yes? Will he say yes? It's about, but what if they don't? What does that mean about me? And what am I going to do with those feelings? I don't think I could handle that. And when people say that, because there are people who will say genuinely, I don't think I could handle that level of rejection. I don't think I could handle that level of exposure, right? That's really clear values. That's really strong acceptance. That's really strong self as context, right? That's them saying, I realize that this is going to be really uncomfortable if it goes a certain way. And I'm either willing to accept that or I'm not, right? My value, I have a greater value elsewhere, which is maybe protecting myself or risk, reward, benefit, you know? But when people are saying, I really want this, I really want connection, or I'm really struggling with isolation, or I really want to be a better whatever, but they don't take steps towards it because what if, it really kind of comes down to the what if is, what if I can't handle the discomfort that comes with it, or the discomfort of what comes if I don't succeed, right? Does that make sense? Yeah, Sabrina.
So is that kind of a part of committed action to take those small steps to feel that discomfort, or is it just like any type of discomfort you want them to?
There are people where it's like, look, we got to take really, really small steps, right? So it might be, you know, what if could you ask the cashier at HB what time it is? Right? Some people are so, and it, you know, it'll depend on what their specific discomfort is about. But yeah, like to your point, some of it is really minute discomfort, right? I had a client once who like, he was very rote. Everything was like to the minute, right? So like, I got to go to bed at 9 o'clock, or, you know, my whole night is wrecked. And it's like, what if you went to bed at like 9:02, right? And then it's like, and he was like, no. And it's like, okay, well, I mean, case in point, right? Like 9:01. And so, yeah, for some people, it's really small steps. I had a peer once who said he used to be a personal trainer. What happens every January with personal trainers? Yeah. So he said, I always get these people, and they're like, oh, I'm gonna run a marathon, right? I'm gonna join the Olympics. I'm gonna go up on the Olympia. And he says, hey, you know, why don't we scale it back, right? And he said there are some people we scale it back to, what if we do a 5K or a half marathon? What if we just go around the block? And he said, and then I have some people who I've got to say, what if we just walk around your house, like outside of it, just go around? And then there are some people I got to say, what if you just put your shoes by the door? And there are some clients where we have to kind of, you know, it's not for want of trying. It is because they're so intensely uncomfortable where it's like, yeah, we might need to go back even further than we initially thought, where it's like, wow, they're really feeling it. And so I guess more specifically to your question, when I've had clients that are that way, it is, let's experience a little bit of discomfort so you can see that you could survive it, right? And so there was, I think I was right where y'all were, like I was in my internship in grad school, and I worked with a teenage boy, and he had really bad, not social anxiety, but like performance anxiety, maybe, like he couldn't speak in front of people. And so it's just me and him, and with me, he was fine. But with others, he was, this very tepid, timid guy. And I said, what if you, like just you and me, it's just us in this room, what if you raised your voice to me, right? What if you just spoke louder than you really needed to? And you could kind of see him like, oh, like, because it's the fear of evaluation that he had, right? And I'm gonna embarrass myself. And I said, well, what if it's just me. What if you just say, instead of saying, I'm really looking forward to the movies this weekend. I'm really looking forward to the movies this weekend, right? And of course, like, he's gonna feel silly doing that. But you see, the world did not split in half, right? And you're still here, I'm still here. Don't ever talk to me that would be messed up if I said that, right? But like, you see how it's okay. And so sometimes we do that, and sometimes you just do it in session where it's really safe. What if you, like clients who you maybe are trying to do something artistic, you're trying to think of an alternative, or you're working with kids. What if you draw me a picture of, how you're feeling or something like that? And I don't want you to laugh. And it's like, well, why don't we both just draw really crappy drawings together? Like, I'll make one too, right? And so they do that to see that, no, that wasn't, I don't like what I drew, but no, I don't feel like you look at me any different either, right? And so it's like, okay, we can build on that, right? And so really small incremental steps. I don't even know if I'm talking to your point anymore.
I mean, sort of kind of in relation to what they.
Yeah, what they're trying to avoid, and then the intensity of what they're worried about. Right? Some people, it's like, I'm worried I'm going to get made fun of. Yeah, I don't want to deal with it. I mean, I know I'll be okay. I just don't want to deal with it. Versus, I could never handle that. I'll have to pack up and move and start a new life. Right? Yeah, it is. And I think Hayes says that in one of his books, that it is ACT is closer to kind of an exposure model than it is maybe like REBT or something like that, because we are ultimately helping them experience discomfort and regulate or manage how they're going to handle that discomfort. We're not trying to take away that they have the thought or anything like that, but to help them realize I can have that and not have it dictate my life. Good questions. Other thoughts, questions?
I just keep thinking about how this can be used for other kinds of populations as well, like neurodivergent populations, especially with that rigidity and
Right.
thought process. I think that's really interesting.
Yeah, I do too.
Ideas.
Yeah, and the thing is that we are always keeping it along those lines, because someone who's neurodivergent, maybe they have many different rules to consider, or they're from a different culture and avoidance looks different, or the values are different. It is a fairly culturally adaptable theory. Now that is my opinion. There aren't studies on how it would look across cultures and things like that, but conceptually, you can adapt that as long as you, as the counselor, are being culturally humble and inclusive in your practice and how you're dialoguing with people. But there is maneuverability, adaptability here to adjust to different cultural aspects, including neurodivergence.
I didn't realize how easy ACT.
Yeah.
I work, all my clients are, well, except for one, are Latinx males. And so in session, they don't realize that they're being vulnerable at times. And they often fear at the state of,
Yeah.
I will not you. And then by the end of the session, they're talking to me like,
Yeah.
so I thought I was more so utilizing, like, I suppose immediacy or approaching, but I think I was using committed action. Like, I was like, okay, well, you were as vulnerable in the session.
Yeah, you took steps towards working on whatever the issue was.
Yeah.
Yeah. So, y'all doing okay? You need a stretch or anything? Yeah, you need to, yeah, Sabrina said yes. We're gonna do what she says. Dr. I is okay if everybody gets like 5 minutes?
Yeah.
Or am I even out of time?
No.
No. I haven't done what, 1, 2? Oh, nice, okay. Huh. Go ahead, Sabrina, you're safe. You can be vulnerable. Yeah, it's actually going to, even with the time. think you said that's me. Like, anytime I've had to. I think you said that on my teaching presentation too. You may have said it like when you dropped me off.
I think I did, yeah.
And then you left
It's my
me.
favorite.
Sharon, you know what this one did? She walks me to the room, doesn't take me to Starbucks or anything. I gotta wander around and find it myself.
What room,
I-
this room?
I took you to the like room for your teaching presentation.
Yeah, I was part of.
Oh, when you were interviewing.
I had to go wander around and find a bottle of water by myself. I could have got lost. I could have been taken. You don't know.
When it's ready, so I'm gonna
Yeah.
send it out.
Can you stick around for the VR demonstration?
I'm thinking about it.
I saw. I didn't think I really knew on that, but I saw.
I added just the references and the bio thingy.
Really cool.
On
I do
the-
have it at the end and now I like more.
But, yeah, we shall see.
Yeah, that's perfect. Yeah, you can take as much time as you want, really, like, we're here till 2, I don't feel like. Or if you're reading it early, right?
No, I don't think I'll get back from this. I go past one.
Okay. Okay, yeah, you have a bunch of extra.
Real.
Yeah. So I kind of.
I like how you said to put it in.
Oh,
It's kind of like they're all going to be take them with them now, and they can kind of like build off of what you've done.
Yeah. Nice.
Most of them. It's a wellness program for students with,
But then like,
What else did that? Like, nothing like, small. Soccer ball.
yeah.
yeah, just like what's it-
Somebody ask a question. I'll think how cool it is.
This is
Where
it.
officers want to value
Oh,
or value
right.
or like it's like observe yourself.
Yeah. I was just gonna look
Sharon.
up the 6 sides.
No, you're talking about your
Yeah,
dissertation.
like maybe you could like.
Yeah.
It's a qualitative exploration, so pretty much just like introducing
Yeah.
and analyzing their experiences.
Yeah.
English is second language,
I
Hispanic
even think like,
students
yeah, like those
in the
like
counseling program.
stress balls
To
or
see
like,
how like the language,
cute.
you know, influence their experience, learning content, presenting content, seeing clients.
Psychological flexibility or something.
Yeah. I like that. Pretty good.
She's close to the friend.
Go.
Yeah, she's doing it now. What stage are you on? So we're on writing the first chapter.
Yeah,
Like,
ACT's best start.
Yeah. So there's 5 chapters, and how long that is, it depends on the kind of study that you're
Yeah.
doing.
So basically like before
In the library.
department, it's kind of educator. So like, but you also put in all of your assessment, like. The other thing, I have big degrees.
Even the references.
Yeah. So I like that.
I'm making like the summer. I mean, like.
But we're in our.
I think so. So you 3 years of classes full time, like 3 classes. Okay, so our last semester we only do 1 class. And some semesters we're also doing dissertations. Dissertation become a lot more. So, but for the most part, it's 2 classes, including spring, fall, and summer. Your last semester is more dedicated. So. To graduate.
We finish all the years of just making that's why I finished some, I'll graduate in like 4 or 5 years, and I thought, how long is it? Now I'm not studying, all like, I enjoyed the program this far. Especially last week, I did that about. So like for. Oh, you have.
Specific lab on, I guess, learning communication stuff. When you have a PhD provision like us, you go through that class. But then, so you take that, you have to be an LPC for 5 years. You can even try to take PCS. After those 5 years, like that, then you have to take that class. And after you take that class, you apply for the license, which is just like a regular, whatever you have to do. They approve it, and they do it. I mean, it doesn't compare to, I think, in class, they can use like a month maybe, like it's not 5 years. Your life. So we don't have to. Maybe
Actually, no, going to Harvard.
Good amount of stuff. I usually volunteer. But I would really have to be like.
All right, ready to get back to it? All right. Oh, wait, I did. Oh.
Yeah, so it's been recording, right? I will click on the more.
I think I.
Oh, I was going. No, it's okay.
Oh, I'm sorry. Am I still sharing? Yeah. Okay. All right. Welcome back, everybody. So, as with all the theories, there are different ways of starting your sessions and doing case conceptualization. This is only one. There is a website, I think it's called Contextual Behavioral Science .com, but that is kind of like the ACT hub, right? And so you can find lots of treatment guides and suggestions. And also like I said, on Facebook, there's the ACT Made Simple Facebook group where other clinicians of different varieties will post client situations and concerns and how do I address this or that. And Russ Harris replies to like every single comment and gives lots of material. So it's a great place to kind of get other ideas. So I share all that to just say this is one way of doing it. It's not the only way. So what's happening? Okay, so our roles, we see the client as a whole person. This is a humanistic approach, right? Client values drive the goals for the sessions and what you're going to do, what you're going to work on. But we do require active participation. It is not only us doing a lot of psychoeducation and you got to diffuse from your thoughts, right? We need to, both of us, the client and us, need to participate in session. And ACT, one of the reasons that Stephen Hayes calls it ACT is because they want you to act it in session. So it's heavier on, let's do this right here, do it right now, let's practice these things, versus let me explain it to you and you go home and try it and then tell me what happens, right? And so it is a very engaged modality. The counselor, your three roles, there is a better word, I didn't choose this one, but instigate, which is, they mean do it, right? Do act, right? Do the role plays, do the thought activities, do the meditations, do all the things, do it there with them, not just explaining and describing it. Model it, meaning that you, when you feel uncomfortable in session, because maybe a client brings something up that you're uncomfortable with, maybe they get upset at you, don't shut it down and don't avoid it. Don't avoid your own session-based discomfort, right? That does not mean you have to be an expert in all of these things, but maybe a client comes to you and he wants to talk about intimacy or sex or drug use or something that maybe you're familiar with, right? Being a survivor of interpersonal violence or grief or whatever, and you feel uncomfortable, model for them how to handle it, right? So yes, there is a little bit of balancing disclosure, but the biggest thing, if nothing else, is don't shy away from it, right? And certainly if you get uncomfortable and act on it, what message does that send to them, right? Look, my own counselor won't be uncomfortable, right? And there is a place to share, you know, when I first heard you say this, or, you know, earlier this week, I was really frustrated and this happened, and be sincere, be genuine, but we do want to model it. And then support, and that goes without saying. In ACT, support is really monitoring and tracking. So if I'm Kendall's client and we're working, and she said, how did it go? Did you go and introduce yourself to that club you wanted to join? And she kind of sees me, like, maybe I look to the side and I'm like, yeah, I did. She will say, hey, it looked like you felt uncomfortable when I asked you that question, right? And so it is a little bit of us leaning into their discomfort also, right? And I think that's true of most theories, if not all theories. The job is not to soothe them. It is to support them through their growth and change. But with ACT especially, if I show Kendall discomfort, it's an opportunity for her to call attention to it and do any of the different techniques and strategies with me and say, well, hold on. You went over that really fast. Think of like when you ask people, oh, how did the other day go? Oh, it went fine. It wasn't anything. And they just kind of blow it off. Like you said that very fast. What happened? Is there some discomfort there? And you can go whatever direction you need to go to with it. Like, can we sit and kind of identify that thought Or what makes it difficult to talk about it right now? And let's work on why it's uncomfortable and what can we do right here in session to experience and manage discomfort. So it's not just support like, you did it, right? It's actually providing opportunities for them to explore and grow. Okay, so you have your client. You obviously do informed consent, because I know one of you pedantics is going to be like, when do you do that at the beginning, right? That doesn't change. But you did your informed consent and everything that goes with it. And it's going to sound pretty standard. What brings you in, right? And they will talk about, most likely, I had this thing happen and now I'm upset. There are some clients, they've been the exception in my experience, where they have a tremendous amount of insight, or maybe they had previous counseling and they're aware and they are able to kind of jump right to something, I'll say deeper. But most of the time it'll be, I went through a breakup, I had a death in the family, this thing happened, that thing happened. And it's just very here and now, which is not a bad thing, but it's not really any of the ACT processes. And in that conversation, you're kind of doing your assessment. How do they display discomfort? When they're telling you, they say, I just went through a breakup, and you say, what was that like? Did they get emotional? Did they seem very vulnerable with you? And did they gloss over it? When you say, hey, you mentioned that you had a passing in your family, tell me about that. And they say, oh, whatever, right? What does that mean? And again, context matters, culture matters. First, what does whatever mean? So we ask the follow-up questions. I know I just got done for like the last 2 hours saying like, it's about avoiding discomfort. We also want to confirm that, right? So one of my peers in my doc program was from Romania, and her mom came to visit, and a group of us took her out and we went to some restaurant, and I was sitting with my peer's mom, and I said, how are you enjoying your food? And she said, it's okay. And I was like, oh my, like, oh, but it is Texas and Romania. That's a big jump, And so it was barbecue, right? And so I was telling my parents, like, oh man, I think we made a mistake by bringing your mom here. Like, I'm so sorry. And she was like, no, in Romania, saying it's okay, when translated into Romania, means it's good. And I was like, but I didn't say it this way. Like, she seemed like she meant it's okay. And she said, no, that is how we display that. It would have been inappropriate for her to, like, yeah, I really loved it. Like, we just don't do that. Right? And so good growth opportunity for me. Also important in our session, that when someone is saying, yeah, it's okay, yeah, it's whatever, was it really whatever, or is it dodging? And that's where you're asking the follow-up questions, like, can you tell me more about that, right? Or what does that mean? And when they're described, when we get to values, right? So there is a section where you're asking, what are the most important things to you? I would not be surprised if you got answers like, oh, I don't know, or they're kind of all over the place. That's normal. It's a really big question, isn't it? Like, if I were to ask you right now, what are the most important values in your life? A lot of you would probably need a minute, or you'd give an answer and then immediately circle back, right? And say, school, work, and family. Well, hang on, no, family, then my health, then my cat, and like you would just kind of go through over and over, adjusting each iteration. But we try and figure out what are the important things in your life, or, what is a life well lived to you? If the problem wasn't there, nice solution focused question, right? If the problem wasn't there, what goals would you achieve? Right? How would your life be different? And then we're going to ask about and observe thoughts and internal experiences, right? What are they showing outwardly, right? So when they talk, again, I just went through a breakup and they're getting emotional, or are they looking very stoic, right? There are those clients who they'll kind of, yeah, I mean, it sucked, right? They're looking away. And so is that them avoiding displaying that discomfort here? Right, so we're trying to piece together a couple big pieces. With the value part, we want to identify core values. Again, we're not focused on single goals. right? The values are the direction that we need to move in. In other words, we need to know values in order to make our treatment plan. Right? Otherwise, it's back to Nora's early question. It's just us kind of dictating this is what we're going to work on, which you wouldn't do with like any client, but with ACT, it's especially important that we're moving according to their values. Discuss their personal goals, right? At the end of our work together, what would you have hoped to achieve? And what keeps you from attaining those goals?
Earlier you mentioned that you have a worksheet that you use.
Mhm.
Is that one of your handouts, or did you already discuss it?
There you go. And I think, this is the one that you brought, the valued living questionnaire, which is online, right? These are just screenshots of it. And it has two sections. This section here is how important are these? And the reason I like giving this, and I give it as a homework assignment at the end of the first session, right? Because again, it's a big question. And it gives them a guide. This is obviously not an exhaustive list of every value that a person could have, but family, marriage, parenting, social life, work, education, recreation, spirituality, citizenship, and physical self-care. And how important are those things to you? There's no right or wrong, right? And you would expect context, culture, development plays a role in what's important, right? Someone like 18 right out of high school going to college probably is higher on friends and social life than on parenting, right? Probably higher than on marriage and couples, or and then people who are very devout in their faith, we'd expect them to maybe rate higher spirituality. Right?
Do you also use this with your couples, like with?
Yeah, that's right. Yeah, you give them to them individually and see where there's some shared values. The other part is the actions that you take, or how consistent are you with moving towards those values? So what sort of discrepancy would stand out to us? What would be an interesting result here? What would we like kind of zoom in on between these two? It's important to me and my consistency with that value. Right. So in other words, somebody rates something really high. This is so important. It's a 10, but I'm a 1 on my consistency with it. And there are other versions. There's one that I kind of like, I took this and added in some text blocks about what does it mean, right? What does spirituality mean to you? What does the marriage mean to you? What does parenting, what does that mean? And then you can also ask questions like, you can phrase it however you like, what are the steps that you take towards it? But this action piece, what does it look like? And usually my clients come back to the next session, and it's not that they have an aha moment, but there's a little bit of emotion where they say, one, I forgot how important one of these is to me, or I always knew it was important, but I didn't realize how far I let it go, right? And there's a little bit of processing there. And when I first started doing this, I was kind of surprised. I don't know why, but I was. And, I think of one client that I worked with for a long time, who he was really struggling with connection, just couldn't seem to find somebody that he could get into or that was equally into him. So he's rating relationships high, and he was also very devout in his faith, and he rated that high. And over here, he was like pumping a ton of energy into finding the right relationship, but then not doing really anything for spirituality. I shouldn't say anything. It wasn't a 1. It was like a 3 or a 4. And that really saddened him because he was like, that is important to me, and I don't want to lose that. And I guess I didn't realize how much I'm pumping all my energy into a romantic relationship or just finding one when I'm not putting that much energy and time into this other thing that's even more important to me. Right? Nora, you're going to ask something.
I was gonna ask if the actions don't line up with the values, would that be reassessed the value?
That's a good question. Thoughts?
Actually, the probably the value.
Mhm.
What that would be, but value can still be there. That person can still feel like spirituality is a value that they respect and want to keep close to them, but they perhaps don't have time for church, or they forget to pray, or something different.
Yeah. Yeah. Sure. Well, the tone though.
Sometimes we have these old narratives, especially like when you were raised, for example, Christian, and then you go on through life and you don't, it's not really fully present. But you still say, yeah, no, it's a very important role despite like it not actually being. At one point it was, but now you're at a different chapter where things change. And so that's where I would see an instance where values would have to be reflected on because of those old templates, old narratives that we have from the stories we live.
Yeah.
And picking up, being back off of that, but when it comes to narratives and how to keep them and try to reprocess it later in our lives, obviously that's an important part. But I can imagine values and commitments in our conflict with actually fulfilling what we feel are our values and commitments. This is very important, but I can imagine if it doesn't directly relate to the presenting problem that the client wants us to address, we might have to make sure later we can actually address it. Though these things can be connected under the right circumstances.
So yeah, the answer to Nora's dismay is both, right? I do think, and you would, right? You would say, well, tell me about the action, and it's kind of like if you keep, you're saying that this is important, and there's another one on top of this that is sometimes helpful, which is how successful do you think you are at this value? So somebody might say, I think friends and social life is really important to me, and I'm putting in max effort, but I still feel unhappy about it. And so either A, and I think this is the spirit of Nora's question, is like, was it because the value maybe isn't as high as they initially said, or are the actions inconsistent? And so you would kind of look at that. Tell me about why you still feel that way. And there is a place to say, could it be that this is not as important, or maybe it's not as important now, because people's values change over time, right? I use myself, like the values I had probably when I was like 10, 15, 20, 30, and now are all very different, right? And so your values can change. It can be, to Megan's point, one of the things when we talked about values clarity is not only confusion, but also being stuck to old or what you think you're supposed to value. And maybe there was a time in your life where you truly did and things change, or maybe you never did, but you were in such a situation that you kind of had to go with it, right? And so the short answer is it will be one of those two, that maybe this is not as important, or maybe it's not as important anymore or right now, or maybe it is important, but these are not, this isn't, the steps aren't leading to success. So you would look at both, and my experience is it is usually one or the other. There is the occasional, think in terms of like cultural communities, you move to maybe a smaller town, and regardless of the cultural factor we use, you feel very isolated. And it's like, I'm doing everything I can, but they don't have, just using spirituality as the example, there is not a place of worship from my religion here. And I'm doing everything I can, and there are online groups, and I'm doing that, but it is not the same, and I don't know what else to do. So sometimes it's like you're doing everything you can, and again, the context is what's there, and so that's where we can talk about the discomfort, right? Acceptance is where I go. So what I try to figure out is what is their tolerance for discomfort. And we explain what acceptance is, right? It's a willingness. We're not trying to reduce emotion, right? We explain pain and suffering, and we talk about, you're trying so hard to do these things. So for example, the person who feels very isolated because in their community, they don't have a cultural community that they're really longing for. but they're trying everything. So when we talk about acceptance, it's, hey, is there a way, is there a place where you can acknowledge how uncomfortable or how aggravating, whatever word you want to use, how uncomfortable it is, and honor your discomfort and honor yourself by saying, I'm doing everything I can, and this is really hard, right? Can you do that? What this survey does, the acceptance and action questionnaire, again, freely online, just helps us kind of evaluate how quickly or how sensitive they are to discomfort, right? My painful experiences and memories make it difficult for me to live a life that I would value. So the question about what if my painful trauma memories keep coming up, that kind of addresses that. I'm afraid of my feelings. I worry about not being able to control my feelings. Painful memories prevent me from having a fulfilling life. Emotion cause problems in my life. It seems like most people are handling their lives better than I am, and worries get in the way of my success. And of course, with any assessment, right, you're not just like, those are the numbers, right? Like you're going over it and asking, like it's cliche, but it's cliche for a reason. Tell me about that, right? Tell me why that's so high, or tell me what makes you so resilient to intense feelings and stuff like that. So we are following up, and not just, that's it, that's the end of the assessment, right? There's a second part. Then we bring up control, right? What if I told you, let me back up. We're going to introduce the concept that the problem is not their feelings or their thoughts. The problem is their attempt to control it. And so we'll talk about control and explain avoidance, control. At the beginning and during the assessment, we're trying to evaluate what has the client's behaviors been for attempting control. So in other words, what have they done to try to control those feelings? So when they say, emotions get in the way of my life, I'm going to say, well, emotions are normal and they happen for everybody. How do you manage that so that they don't get in the way of your life? You know, what do you do when an emotion comes up? And, you know, oh, I just shut it down. I go to the gym, I eat, I do whatever. And so we're trying to piece together what behaviors they use to control their emotions. And then there's kind of this question of, what if you didn't do that? And what response do you think you'll get? You know, like, why would I do that? Who wants to feel bad? You're not feeling great, right? If what you were doing was working, we wouldn't be here, right? Not to be a smart aleck, I was gonna say something else. And so then we introduced this idea of creative hopelessness, which is when the person comes in and they say, I've tried everything, right? And there's a lot of motivational interviewing that will make this process so much more smooth and efficient for you. And so you're rolling with resistance. There might be some frustration. And, you know, what have you tried? And I'm like, well, I tried getting a life coach. I tried going to the gym. I tried not thinking about it. And so we're acknowledging that. So yeah, you tried everything. You even tried ignoring it. You tried drinking it away. You tried self-soothing. You've tried arguing. You've tried everything. And usually they will start feeling really bad, right? Because I'm essentially pointing out all of your attempts that haven't worked. Very counterintuitive. And so sounds like you've tried everything. And that's the hopelessness part of creative hopelessness. And now we say, what if you didn't try to control it? What if you just let it be? And they'll say no. Because again, like I said, who wants to feel bad? And it's like, well, you've tried everything else, right? The only thing left to try is nothing. Don't try to control it. And they will, you know, oh, like, what does that mean? And then we can explain that what if we just let those thoughts and those feelings be? What if you didn't try to wash them out or mute them? What if you just let it happen? And that's creative hopelessness. Like they got to a point where I'm gonna say desperate, and it's kind of a judgy word, but I'm so desperate to live my life, to do these things that I'll try anything, including letting myself feel bad, right? And that's where we're kind of entering into the agreement of like, this is what ACT is gonna be. As we move on, Jen brought this up, that the ACT matrix. We're looking at 2 dimensions: outer experiences, your 5 senses, what's happening outside of you, and your inner experiences. And then, are you moving towards your goals or away from your goals? I should have numbered this. We're going to start here with values. Who and what is important to you, right? That's an inner experience, right? Your values are not like out, like the platonic form for you to manipulate. And are you moving towards them or away? Then we'll look at things you could do to get closer to your values. What actions could you take? Could you keep taking? Because maybe they're doing some. Then we get to the working part. Go down here. When thoughts and feelings show up that are uncomfortable, or when things get tough, what do you do? What do you do when when that negative self-talk happens? When those thoughts occur, when those feelings show up? We're looking at fusion. Or when they get tough. And when they show up in general, what do you do? Right? So going towards your goals is not going to be an easy feat, right? You're working towards something. Growth is uncomfortable. Working towards something is uncomfortable. And so it's not always going to be easy. So if you're saying, for y'all, for example, you want to be a counselor, you want to be a faculty member, when it gets difficult, what do? Do you do things that move you towards your goals or away? When you're just kind of minding your own business, in other words, and painful experiences show up, like, oh my God, I remember when I was in high school, I called my teacher mom or something like that from Modern Family. I did not actually do that. What do I do with that thought? What do I do with those feelings? Am I doing stuff that moves me closer? So for example, studying for comps in the NCE, and you start feeling overwhelmed. This is what I do. There was a long period of time where I would procrastinate because it's like, oh, I don't want to think about it anymore. I don't want to deal with it. But that keeps me away from my goals, right? Which keeps me away from my values. Versus I feel really uncomfortable about it. Maybe that feeling will pass, right? If I just let it be. But if I keep avoiding studying, because then I start thinking, what if I fail? Well, then I'm not studying, right? So what am I doing? And that's where we say, when specific instances come up, we go to our choice point. So Kendall's with her client, and she knows that her client's getting ready to take the GRE. And she says, how's the GRE studying going? And he says, well, I didn't have any plans this weekend, and I was going to study all weekend. And now the door's open for Kendall to say, okay, you had a choice, right? And then some friends invited me out. But I know that I have the GREs this week. And Kendall's gonna say, well, what did you do? And the hooked feelings might be, I'm so afraid of the GRE that I want to avoid it. It might be that I'm so afraid of rejection, like I can't, like FOMO, right? Like if I don't go out every time I'm invited, they're gonna stop being my friends, right? So I'm staying here and I get hooked on my thoughts and my feelings, and I make choices that move me away from my goals, right? And so that might be the fear of failure. It might be just the fear of taking a test. Fear of taking the GRE means I'm getting closer to the next step in what I'm going to do, and that can be overwhelming. It could be I felt lonely. I usually study in a group, but that group was out this weekend. I didn't want to be by myself, so I went out with some other friends, but I didn't study, right? And so versus, yeah, I felt really uncomfortable. There was no one there for me to talk to, and you know, I don't like going to the library by myself. It's just kind of uncomfortable, but I did it because I really want to do well in the GRE. It's really important that I get into grad school or whatever program. And so that's where we're exempt. And we would think as they get better at those ACT processes, they're going to start moving towards more often and more consistent. Does that make sense? Diffusing. So when we're talking about thoughts, there's a couple things we talk about. The ubiquity of thoughts, which is just that everybody has thoughts. Thoughts happen all the time. You're not going to not have thoughts, right? So we have to find a way to manage them, to interact with them. And the literality of thought. So it goes back to the rainbow and Sabrina's pot of gold, right? That not every thought you have is true, right? They are conditioned responses. They're automatic, right? So I say NCE, I say comps, I say license, I say dissertation. And you kind of, you know, get the heaves. And you have a reaction like, oh, it's over, I gotta do this and this and this and this. And you get overwhelmed, and so you shut the thought out. And it's just a conditioned response, right? What if you fail and you kind of tighten up? Oh my, because failure, you know, even think of societal messages. Failure is not an option, right? For boys, big boys don't cry, to be a man, right? So when I feel an emotion, I have a thought, I act on it automatically, and that's implicit, right? That's the word for it. They implicitly happen. And so why should we, or what we're explaining to them is that why should we engage those thoughts and take them as literal truths when they are just conditioned responses, the same as what is at the end of a rainbow, right? Nobody thinks literally there is or that there is a literal pot of gold there. We acknowledge that there is the thought and it's not real. And there's a lot of other examples that you could use. Right? So why do we give so much credence to some thoughts and not others? Why is it so easy to dismiss? You better behave, Santa's watching, but not so easy to dismiss, I'm gonna fail. Or why is it easy, why is it so difficult to accept maybe things will go right? Right, and so a lot of it is because it's conditioned and we're afraid, right? Because with my thoughts are, what if I'm right? What if I do fail? What if I am rejected? And that's where we talk about right, but the initial thought that you're going to be rejected was just a conditioned response, right? It came from maybe a truly negative experience you had. But again, just because you think it doesn't mean it's going to be true, right? And that is a really difficult thing for some clients to manage. And again, we're not disputing the veracity. It's more of, okay, you have the thought. What can you do so that you're still moving towards your values while having the thought, right? Because we can go back and forth forever. And that's, for me, that was the big switch from CBT to ACT, is that with CBT it would be, what evidence do you have? Why do you think it's going to be this way? Think of how much you've grown, right? This is a different group. And you will keep saying, as my client, you will keep saying, yeah, but, yeah, but, yeah, but, yeah, but. And the truth is you might be right? Price might, I would hope this would never happen. Price might get rejected. You might just wind up with a group of jerks, because who would not accept Price? So instead, we got to find a way to hold that thought, acknowledge it, and move forward with it rather than trying to change it or remove it, right? Again, we can't create or destroy, right? So we got to do something else with it. Now, part of that, because we're explaining it and we're going through that, we want to set the stage for the next question is, well, what do I do? How do I catch them? They just seem to happen, right? Maybe you guys can relate. I know I can. You're not mindful 100% of the time. Sometimes you're just like, I didn't even realize I was in a funk. The other day I picked up my daughter from school, and I had something on my mind. There was just something really kind of time sensitive I had to take care of. And I was in the car, and I was, that feeling of like, oh, come on, if I could just get home, I'd take care of this so fast. And she got in the car, and I was trying to be, a loving dad. And I was like, hi, beautiful, how was your day? And she immediately was like, what's wrong? And it broke my heart because like, I don't want her to feel that way. And I was like, oh, nothing, what are you talking about? And she was like, okay. And so she's like, are you sure you're okay? And I was like, yes, of course, what are you talking about? It's a great day, it's Friday. And then she asked one more time, and then she kind of stopped. And just because I know her, because she's my actual kid, it was her resigning, like, okay, he's not going to talk about it. And I got home and took care of it, and I had that wave of relief. And I went to her name's Poppy, and I was like, Poppy, I'm sorry I didn't tell you in the car. I was really overwhelmed, actually. You were right. You're so smart, right? You called it. And thank you for checking on me. Because that's how counselors talk to their kids. And you're right. And as I told her, I said, because she doesn't know like what I do, like he teaches and writes. And so I said I had to send something to somebody. And when I said it, I felt so much better and lighter. And I said, and I told her, I wish I would have told you sooner because now I just kind of feel better. My point is that when she got in the car, I wasn't aware of how much it was on my mind. I wasn't aware of how it was making me feel. I wasn't aware of the tension. And I will absolutely admit, since it's like fresh on my mind, yesterday when we were in the car, I was actively telling myself, just don't think about it, it'll be okay. Don't waste your time thinking about it. When really, if I had just kind of said it out loud, it probably would have gone away, right? And so you don't always catch yourself though, and this will happen, it happens to everybody. But that's why we focus on the mindfulness skills as appropriate based on age and culture and context, right? Because maybe they don't have, an hour a day to themselves. And so the skill is to maybe check on themselves throughout the day. I'm a big fan of journaling, and I often tell clients to do that. For people who are really, they have a lot of anxiety and angst, set an alarm on your phone to check in on yourself every couple of hours, right? To just, even for a minute, just fill out a diary card, right? Google DBT diary cards. They have a million that are, available and client friendly, but we want them to get in the habit of checking in with themselves and then move into, great, so I'm practicing mindfulness, I'm aware of what bothers me. So what? Now can you imagine yourself just having the thought without experiencing all the stuff that comes with it? Such as Jan's like really great example, which I'm gonna probably butcher up now, of you have this ideal self that you're trying to be, because you think that's what you're supposed to be, and you have all the pressure that comes with it. Can you just imagine a place where you're your authentic self, you happen to be having these thoughts, right? They're not, they don't need to dictate how you're going to act or feel in this moment. All right, so that was it. So very quickly, because no, I actually wound up going over. For integrated behavioral health, for any questions on this, this is a very broad case conceptualization. And there are worksheets that you can use to help map it. For integrated behavioral health, it's really good for conditions where lifestyle changes are needed, right? So think of people who maybe are diagnosed with diabetes, type 2 diabetes, right? Where they're going to have to really focus on diet and exercise, medication. Any health issue that does require medication compliance, especially if the medication comes with side effects, right? And so there are lots of studies, and there are meta-analyses, which is the study of studies, on ACT for weight management, metabolic issues, and we're seeing more now on diabetes. There's a lot on using ACT with people going through chemo or people with cancer. a tremendous amount on pain and physical therapy. For chronic pain, and then probably the discomfort that comes with physical therapy. And what it would look like is somebody who is maybe diagnosed with type 2 diabetes. What do you value? And they say, well, I want to be there for my family, or I want to have an active life. And to do that, it requires certain changes in your life, and that's going to be uncomfortable. Or even people with psychiatric concerns where I need to take medication because maybe I have a schizophrenia or even a mood disorder, right? But I don't like the idea of needing medication, right? Maybe some of you have already had a client. I don't want to have to take a pill to be happy. Well, you're like not happy now anyway, right? So it's gambling with house money. And so I don't want to deal with this or that side effect, but I also want to be healthy for my family. Or I have these other things. I want to be successful, or I want to be healthy. And it's like, these are the steps towards it. They are uncomfortable steps though, right? Somebody who needs physical therapy, maybe they have an injury, and they're saying, but I really value being able to, or a goal of mine, not necessarily a value, is to travel. And I want to go do these things, and I want to make memories with my family or my loved ones, right? That might be the value. But I can't do what I used to do because of this injury or whatever. But physical therapy is so painful, right? And so we're working with them on the discomfort of the physical pain, along with maybe the discomfort of how did I get here and why did this happen to me, and working through it. So lots of studies about the effectiveness of it for that. There's also a lot of research on using it in apps or online for web services to make it more accessible to clients or patients, depending on where you're at, in rural communities, or who maybe they need specialist care that's further away. And so having something available online has been effective. I think that might be it. Oh, some additional readings aside from the book that you gave, and this is a series. They have a couple of these, and then they have one for like body image and eating disorders, and an advanced one. But I 100%, if ACT is something that calls out to you, I really recommend all 4 of these books. Things might go horribly, terribly, or terribly, horribly wrong is great for you and for clients. This one is probably more counselor centric, right? It's more about doing it. Some clients might be able to do that if they're like really invested in it. And then ACT Made Simple is by Russ Harris. And it's very, very good. It is definitely written for people who want to practice, and it's very practical exercises and has handouts and worksheets. And this is the Facebook group I keep referring to. That's what this one is based off of, and he freely gives excerpts from his books or worksheets and things like that. It's a very engaged community. So I definitely recommend it if you have Facebook or social media to check out that group. And now I will take any questions. Yeah.
Due to the practice-based CT in general, we obviously have to maintain the distance with all our missing, and that's basically comfortably fine all the time to maintain that position. Here's my question was, how do you deal with that after the fact? But now my question is more so, are there techniques to maintain that to keep that rawness going without it, like, I guess, how do you kick the habit of trying to avoid this a lot?
Help me understand the question a little bit better.
I would say, I guess it just depends. Some people might not just like this therapy in general because they can't really enter that space. But I guess for some people who are having difficulty with getting into that space and even deep for it.
Got it.
What are some tips that we could use to get to that space, or at least maintain?
Yeah, so I go full transparent with clients, just like I do with y'all, which is being uncomfortable is a requirement for this process. I say it more cheerfully than I'm saying it now. Are you ready for that? Is this a good time for you? And some motivational interviews. So somebody who is, if somebody is like, yeah, I'm ready, it's like, great. That takes care of itself. The person who's kind of like, no, I'm not, that kind of takes care of itself too. And you say, okay, that's all right. Call me in when you want to give it a try. The person in the middle is the one that we're really working with, the one who's unsure. And that's where I say, well, it is going to be uncomfortable. And just like life, you know, there's no avoiding, we're going to have to at some point experience some discomfort. We don't have to dive in headfirst into the deep end though. And so there is you know, a little bit of like using the gas and the brake, right? There are times where you can lean forward. And then there are times where it's kind of like, okay, maybe just today is not the day, or maybe that's not the type of discomfort to explore with them. But you're kind of keeping a pulse on the situation. The thing that I would recommend is constantly checking in and just saying, tell me how you're feeling, because the discomfort they're feeling about feeling discomfort is relevant. So what can we do to make you more accepting or more willing to experience discomfort even here, right? And they might say, I just can't, it's not a good time in my life to do this, I got too much going on. They might have a very, all the reasons are valid. I'm not comfortable talking to you about it, right? And so just like Jill in the case study, she didn't like working with the psychiatrist because he was an imposing man. I've had clients not want to discuss certain issues with me because I'm a guy, you know? And so trying to figure that out helps us get them set up, even if it's not with us. But I guess the answer is checking in and seeing where can we change things, and are those changes productive? Sure, Sabrina.
But the way that APP is similar to CBT, and in CBT you kind of figure out the core beliefs from the automatic thoughts. And so I'm trying to find the connection of an ACT from their values. Are you challenging the thoughts that they're having, where they have the inconsistency of how their values are not consistent with what they're actually doing? Or like, how do you, what's the thought?
Yeah, so for mine, I don't think I really challenge them on it, but it is, let's talk about it. How I usually say, you know, just like I do, they're like, help me understand, you know, and so you're saying that this is important and I believe you. It seems really difficult. Was there a time when things were different? And, you know, I'll get, well, there was a time when I did all these things, but now I don't. And I'll say, well, what changed? And it kind of goes back to Nora's question about, was it a change in value or a change in action? So don't think it's so much about challenging it. Like, we're not insinuating, hey, maybe this isn't as important to you, but it is broaching the topic of, well, what makes it difficult? And when we start getting answers like, I just don't want to. Oh, well, like internally, I'm thinking that doesn't sound like it's that important then. And I'm sure there's a better way of addressing it, but I would say, oh, well, could it be that the importance of this has changed? Do you still think it's as important? I do try to do it as in non-leading a way as I can, and sometimes it's not always perfect. But that's what it would be, is like, we're trying to figure that out. But yeah, we're not outright challenging just like we would with CBT. We're like, well, you said this and you did that. It's more of a, what do you think about it? That's a good question. And you phrased it well.
I think I want to speak to that because
Sure.
I like to sometimes incorporate CBT and ACT
Mhm.
in certain instances. So, like for example, if we're we're doing CBT and we did like a thought log, and we're going on to building awareness of thinking errors, right? Then like how I might handle that is that, you know, if they got to this place where they can identify the presence of a thinking error in the moment, and they can also identify that, of course, this is a thinking error because it doesn't align with my values also, then can we then use like leaves on a stream and just kind of allow it to pass instead of holding our attention?
Mhm.
You know, or other types of like metaphors. I use like a two-trail metaphor, just like, this thought came up, you know, says I'm a loser or XYZ. Am I going to follow that thought? Am I going to have my attention on that thought? Because I know where it's going to lead. It's going to lead to all these other types of thoughts coming up. But can I bring my attention more to the thoughts that are more aligned with my values?
Mhm.
I know where those are going to be, you know, so I'm not challenging the thoughts that come up. I'm just kind of pivoting my attention away from the thoughts that are going to serve.
Yeah, like choosing to focus on the more consistent thoughts or value consistent thoughts. Yeah.
Yeah, I guess that's kind of where I was going. Like we were talking about
values and all the other actions that you could do, I was kind of also comparing it with like a core belief.
I see.
How you would use committed action to then like prove that that core belief isn't real, it's irrational.
Yeah.
Go through the steps.
Well, and there's a place to, you know, to, they're not mutually exclusive, right? Someone can have this really early fundamental experience that led to a negative core belief. And that does dictate maybe the magnitude and the value of the thoughts, like if they're good or bad or helpful or not. And there is a place where you can incorporate CBT and talk about, just because I do this doesn't mean that I absolutely ask, so Brandon, where did that thought come from? You know, and which is a very CBT thing. And I do have clients where we kind of, if you were to watch all of my sessions, it would be like, hey, Leaf, like you started at ACT and like ended at CBT. And I'd say, yeah, I could see that, because we wound up, a lot of what was happening here had to deal with something way deep down inside that needed addressing. Sure.
As far as, I guess, the time that it takes grace with the amount of session, also do you usually, I guess if there are more issues, like not just one value that they're having trouble with, they usually touch on one thing and then kind of they're good with that and then move on.
No, that's a good question. What I work with mostly is increasing the ability to handle and manage discomfort, because I think if they can handle that, they can handle the rest of what's going on without. Right. Yeah, so yeah, that's exactly right. And so it would be the equivalent of like when we talk with teenagers and kids, we talk about stress management or anger management. We don't go issue by issue, like anger with mom, anger with dad, anger at school. We say anger in general, and the expectation, if everything goes right, they're able to handle anger in all situations. And so if we get them to the place of like, they can recognize their thoughts and feelings and discomfort and utilize the skills to manage it, that should apply in other situations, including value-based things. That's a good question.
What's your favorite metaphor?
I really like the sky and the pond one, you know, like you are not your thoughts, right? I think that's really powerful, and it gives like such a nice visual, like whether I like pull something up on a computer or just even like in your own mind, like you can kind of picture that. But I like that one a lot. And then the piggybacking off of that, the activity of like, if you were a director directing someone who's playing you, what would you do? I like those a lot. It's a very metaphor-based approach, right? In fact, there is a book called The Big Book of ACT Metaphors, right? They got a metaphor for everything, right? Real quick, and then if there's other questions, some limitations and contraindications, right? So in terms of couples counseling, because I do like all the families and couple stuff here, is if there is the pathological violence, right? So not the mutual shoving and name calling, but like when someone is truly and severely abusive over another person, we would hold off because we need to get safety first, and the abusive person needs to kind of figure that out before we can do couples. The other thing is with addiction, it's a case-by-case thing, and I think it truly depends on the substance and the severity. Someone who is kind of recreational and heavily using is a lot different than somebody who is in an active addiction, and that's different from someone who's in an active addiction with physical dependence, right? So such as with like heroin or opioids, or like even with alcohol, to the point where it's like, hey, we need to do some medical detox first, and then once we kind of square away the effects of the drugs and addiction, then we can. Besides, if they're actively and heavily using, their values are going to change every time you see them, right? They just got in a fight about their drinking. They're going to come to you and say, I got to stop. I need to save my marriage. And then things will smooth over, and it's like, I'm going to do this now. And she says I drink too much. She's trying to control me. I don't want to do that. And so we got to kind of we need clarity to focus on the values. And then finally, with some disorders, I do think there's an upper limit where the symptoms can be so severe that it's like, we can't do some of these things until we calm down the severity of those symptoms. It doesn't need to be, they don't need to be absent of symptoms. It's more of, can they stay with us long enough to do the activities, to answer the questions? Or just like with substance use, are the symptoms so severe that they're losing touch with reality? And that's not just things like thought disorders like schizophrenia. You can be so depressed that I have no values, nothing matters, because everything hurts, right? So severity of symptoms would also be something that I would caution, and you would know that during all of these things during your intake. Otherwise, it's pretty useful. Other thoughts, questions?
Have you ever used the whole I am versus I am not?
I haven't. I know what it is, but I haven't really done that. I don't, now that you're asking me, I don't really have a reason why I haven't, other than I guess the opportunity just never really kind of presented itself. No, that was kind of a lackluster response. Did you do this? No. End of discussion. All right, well, I'll post, I'll send my PowerPoint to Sharon. And then if y'all need other ACT resources or you have questions, let me know. Thank you so much.
Thank you so much, Dr. Lee. That was excellent.
Thank you.
So if you all would like to take a break, we still have an activity. We're going to end at 2 o'clock. But if y'all want to take a break, y'all are ready to jump right in? Okay. If y'all need to excuse yourselves for a little bit, that's fine. We're probably going to go ahead and just jump right in.